2 minutes past.
Let's start. Yeah.
You can start.
Thank you so much. Good morning, all. Welcome to HTIC Healthcare Conclave. It is happy to see all of you with us. So today, starting with the session, I first like to welcome Mr. Muthu Singaran, CEO IITM HTIC Medtech Incubator, to give away the opening remarks.
Good morning. Thank you, Ashwini, for introduction, and also thank you to have so many of you here. I mean, it's going to be a great conclave this morning. We have got two Padma-Shri awardees spending time with us, both very successful in their own fields. And we have our good friend, Manesh Diwan from Bayrak, and also my other dear friend, Sunil, is coming all the way from Seattle. Thank you so much, Sunil, for logging in. Must be late there at the moment. And we have my faculty who's got COVID, but he's still here. And of course, half the team has got COVID, but that's not much you can do, I guess. So, and as we were speaking earlier, COVID is probably very much related to what we're going to talk about today in telehealth. So with that, I don't want to say much. We're going to have a great panel discussion. We have some of the finest people in the medical profession and engineering. A lot of young startups, very young startups are going to present what they are doing to give them an exposure. So with that, I'm going to pass it back to Harshini. A great day, and let's keep it as interactive as possible. And thank you to all of you for giving us tremendous support to HTIC, as the focus for HTIC is to build the ecosystem, not only in Chennai, but also around the country, and to finally, hopefully, we get plenty of healthcare startups coming to make healthcare affordable, accessible, and reliable in the country. Thank you so much.
Thank you, sir. Thank you so much for setting the pace for the session. So now I would like to welcome Dr. Mohanashankar Sivaprakasam, faculty in charge HTIC, to give away the welcome address. Over to you, sir.
Yeah, thank you. Really happy to be here. And we're just catching up with Dr. Mohan, Dr. Shroff, and so many of our friends are here. I feel like I'm in a physical meeting practically. So, you'll be hearing a lot from the panels. What I wanted to just make few comments, and I want you to reflect on these. And we have been looking at these trends for the last 2 to 3 years particularly. And what does this mean for startups? What does this mean for healthcare? What does this mean for investments, returns, and at the end of the day, the outcome? So if we look at today, about 3.5 to 4% of GDP is what is the healthcare spend in India. And whether we'll get to 5 trillion in 6 years, 7 years, 10 years, that actually is somewhat irrelevant, because we will get to 5 trillion, which essentially means this will double. Right? And this may come as a big surprise, but actually that's really how most of the developing economies work. So this 100 billion, 80 to 100 billion healthcare spend today will double in the next 7 to 10 years. And somebody like Dr. Mohan can tell you, it's not going to double by doubling the current infrastructure, the hospitals alone. It's going to take some new shapes, new forms, and new models. And let us now ask, what does new mean? So if you look at a cross-section of Indian healthcare today, and we are in a very fortunate, somewhat spoiled ecosystem in Chennai. I mean, we have like 25,000 beds. Probably the bed to population ratio in Chennai is as good as almost Scandinavia. So it's a very different kind of population. So in a population like this, market like this, you will see more and more emphasis on quality, convenience, and I use the word convenience. It may not be a word which we would have lightly used 5 to 10 years ago. But today I can clearly see, when I just stand in a OP in a hospital, I look around, what I see is people are willing to adapt, pay additionally a premium for convenience and quality. Quality, of course, is not going to be an issue. It cannot be even a trade-off anymore, I think, going forward for next 5 to 7 to 10 years. So that is one type of innovations and healthcare, and telehealth falls into that also. Telehealth does not necessarily mean a poorer choice anymore. In fact, it is being offered as even a premium offering in some cases. And then, of course, the larger section of the country, probably 60, maybe even 70% of the country, will now slowly move towards where Tamil Nadu moved from probably late 70s to early 80s to 90s today, and then where it is today. So access and affordability will be another driver in creating this other $100 billion. Right? And this, you can already see that. I mean, I don't know how many of you have seen simple numbers like how much is being given to set up a new AIMS. I mean, these are not small numbers. There may be execution issues, things may take time, but the numbers are not small. Right? And when you take a wider view, when you have 10 AIMS set up, I mean, that is a minimum capital cost of 10,000 crores that goes into it. So for startups and innovators, and I don't want to make a comment on the policy aspect today. We'll just stick to innovations, technology, and businesses that will be built out, new enterprise that will be built out. It really is an excellent opportunity. I mean, 5 to 7 years ago, healthcare was sort of twiddling its thumb, saying, where will it go? So now it's very clear. It's going to double in the next 10 years or so. And that white space is going to be filled by new age technologies and also new business models, which will address the aspects which I was talking to you about: quality, convenience, affordability, access, and then so on. But largely, these are the 4 pillars I see. And one comment I have about enterprises in healthcare, be it delivery enterprises or be it technology enterprises, is you cannot operate in isolation as a sort of a non-ecosystem company. Right? So not typically, when you say a company, it gets something from somewhere and delivers something to the other end of the funnel. In healthcare, I found largely dealing with about 40-45 companies at HTIC and so many other companies that I personally have dealt with and we as the organization are working with. You really have to have an end-to-end understanding of the value of healthcare. Where does it flow? In fact, I find many of the startups or even established companies do not understand healthcare is, at the end of the day, a service business. Right? So 50 to 60% of your cost actually is human cost. So the understanding of how does value get propagated, where is my operating cost, where is my capital cost, and what is my return on investment, who is really my customer. So this is a classic trap which most of the healthcare companies I see falling in. They think patients are their customer. It turns out actually it's not. It's actually hospitals are your customers. For hospitals, patients are their customers. So this articulation, this clarity of understanding, and if you overlay it with your abilities, and of course HTIC is there to support you. We are now one of the leading Medtech incubators in the southern region. Thanks to Muthu, it is the leading Medtech incubator, and BIRAC has promised to support us continuously for the next coming years also. So we are here to help you grow. And really, COVID has ironically brought the focus back on healthcare. In fact, we are now starting to see even ancillary, what would not have been called healthcare company, be it infection, disinfection, be it sanitation and hygiene. That's all become now focused into the healthcare. And with more and more disposable income and with what I would call as attention to oneself has increased, it's really a huge scope for the next 5 to 7 years. So please take advantage of what you have today. It's not an easy lineup to get, where they're literally giving it to you right next to your device. Please take advantage of that, and we are there to help you when you need help with your technology enterprise. Thank you very much.
Thank you, sir. Thank you so much for sharing your valuable insights with us. Next, I would like to welcome Dr. Sudhakaran, General Manager at Golden Jubilee Biotech Park for Women's Society, to share the update on Tamil Nadu.
Cluster has been quite active ever since it's formed. So thanks to Dr. Manish especially for the great initiative which he took about a couple of years or 3 years back. And also thanks to Dr. Muthu Singaram for having it religiously month on month, calling all the Tamil Nadu cluster incubators, and everyone has been very much participative and trying to help each other. Thanks to Dr. Muthu as well as the team from HTIC for organizing this on a month-on-month basis. Almost about 15 to 16 the cluster meeting we have already completed, and it's going from strength to strength. With the recent activities, I would like to update that Sastra University that's organizing the mentorship program for the startups in the cluster. Then PSG STEP, they have organized ISBA conference, which was inaugurated by Honorable Tamil Nadu CM Mr. M.K. Stalin very recently. So that has been organized recently. And HTIC, they have again started the AMA series, that is Ask Me Anything session. So with that, many startups, they are getting a benefit, and most of the doubts which are getting cleared for the incubators, when they are pre-incubation stage itself, they are getting a lot of queries answered, and then they are put in the right direction, right path, so that they can become a successful entrepreneur down the line. Then VIT has organized the special invest program, and out of which about 11 startup pitch type, almost about 7 they have been directed to Chennai Angels for the productive investment. So these are some of the activities which we have been doing it. And as far as Golden Jubilee Biotech Park for Women Society is concerned, thanks to BIRAC and thanks to Dr. Manish and his team, with the BIRAC seed fund, we were able to invest with the startup who are into manufacturing of pharma intermediaries using the green chemistry. So we have invested BIRAC seed fund of 30 lakhs, and they have started gearing up their manufacturing and R&D. We have also got the Startup India Seed Fund, and with the Startup India Seed Fund, we were able to invest in 2 companies. One is into oral diagnostic cancer, non-invasive diagnostic device, in vitro diagnostic kit, which they are developing manufacturing one with the disease resistant. So we are able to invest about 20 lakhs each the Startup India Seed Fund scheme. So thanks to Startup India.
Dr. Sudhakaran, sorry to interrupt. We've lost you. We're not able to hear you.
So these are some of the thank you.
Sorry, sir. Guess we lost you in the last. Can you hear us?
I think it's okay, Sunita. Rashini, let's.
Okay.
Yeah, last I was.
Thank you, sir. Thank you so much for joining us and sharing the update. Next, I would like to welcome Dr. Manish Diwan, Strategy, Partnership and Entrepreneurship Head at BIRAC, to give away the keynote address. Over to you, sir.
Thank you so much, and good morning, everybody. Dr. Sunil, Dr. Mohan Shankar, Muthu, Dr. Sudhakaran. I think today we can expect a very intense and engaging discussion on quite an important aspect of telemedicine. This is a need of the hour, and COVID has actually recognized, brought this to forefront, that the physical infrastructure, the conventional way of administration of healthcare delivery, not only to the resource rich but also to resource low resource setting, there is a great deal of gap, and we must act together and work in this direction. While I congratulate Muthu and the Tamil Nadu BioNest cluster to undertake such an important discussion at this time. At the same time, I would also like to introduce that along with this discussion, you might be able to inspire and attract the right talent who would like to work in this direction. As an enabler, BIRAC TBT, we are happy to announce that we have, with the intent to reimagine the healthcare delivery and potentially touching billions of lives, we have rolled out a special program, funding program under the banner Amrit Grand Challenge Jan Care. This has been launched on yesterday, 26th of January. And under this program, we would be supporting 75 innovations who are at 3 different stages: ideation to POC, pre-commercialization, and those solutions which are already there for deployment at the large-scale multi-level field trials. These 75 solutions are working in telemedicine, digital care. Sorry, just 1 second. Ma'am, I'll... apologize for this, some engagement. So under these 75 innovations would be identified for digital health tech, telemedicine, mobile health, using blockchain, IT, ML, AI, ML, and big data. And there are 6 categories essentially that would get facilitated. I'll just name them so that everybody can be aware of it. First is access to primary healthcare in tier 2, tier 3 cities and rural settings. That would include low-cost, scalable solutions that can stay relevant for a good amount of lifespan, and they can offer synergy between physical and digital or hybrid primary healthcare system. Second category is solutions that can enhance patient compliance. That would include patient tracking systems, patient health record management, enrollment system, patients triaging, digital identity, health protection, as well as health promotion, leading to patient compliance, home care, etc. Third category is health data collection, predictive analysis, and digital learning in medicine. This includes image-based diagnosis, solutions that can help clinicians for decision support, smart and connected hospitals, so that the hospitals can utilize data generated from any one place cohesively, early screening, as well as tertiary prevention of disease progression to severity, sometimes leading to disability delay. So decision support system, self-learning, training solutions. We are also looking at computation, predictive analysis at both local as well as a global level. Fourth is data privacy, data storage, and data security solutions. Under this, the federated learning models, offline, online, hybrid healthcare models, self-learning management systems, healthcare financing, healthcare insurance, data integration solutions, exchange of information solutions would fall in. Fifth category pertains to solutions for improved community outreach, interventions to facilitate to and through ASHA workers so that we can reach to the last mile, supply chain technologies, logistics, resource allocation tool that can serve both at local as well as national level, a digital bridge for a connected healthcare system. And sixth is the data-driven modeling that can enable the service industry, the pharma, biopharma, research, development, and innovation. So under these 6 categories, we are inviting applications from individuals, startups, companies, teams, academia teams that can come together and address any of such solutions. And we look forward that these solutions would gel well and align with the National Health Digital Mission and leading us to Ayushman Bharat, the national mission objective. So the call would stay open until 31st of March. And I'm glad that this session is coming right on the very next day. We will also be carrying out some webinars with experts, like so that they can reflect and inspire and clarify people that what could be the potential of working in this field and creating new solutions. I'll stop here. Thank you very much for having me here. Thank you.
Thank you so much, sir. Thank you so much for joining us, and thank you for your constant support. Hope the programs and webinars mentioned by you are of great help to all the budding innovators and entrepreneurs. Thank you so much for joining us. So next in line, we have with us Dr. V. Mohan, chairman of Dr. Mohan's Diabetes Specialty Center, and with an H index of 141 and over 161,000 citations of his work. He runs a chain of around 50 diabetes centers in 32 cities in India and is interested in the prevention of diabetes and helping people with diabetes live a long and healthy life and to reverse type 2 diabetes wherever possible. Happy to have you with us.
Very much. Can I share my screen, please?
Sure,
if this
sure.
is taken off, I can then.
Yeah,
try.
I'll do that. Yes, sir. Please go ahead.
Yeah. Can you see it now?
Yes, sir.
Thank you very much. Good morning, everyone. I can't tell you what a great honor and privilege it is for me to be part of this great think tank. Some of the best brains in the country have come together. Thank you, Dr. Muthu Singaram, for putting this together and for inviting me. Dr. Mohan Shankar, despite your COVID, you're able to make it. Thank you very much. Dr. Sudhakar, nice to listen to you. We are also proud to be part of the Women's Biotech Park, as you know. Dr. Manish Diwan, that was really, really inspiring. I mean, to talk about those 75 innovations that you're going to support in the 6 areas. I hope you can send us the link to that as a friend from college, Dr. Professor Ganapati, Dr. Sheila John, and Dr. Professor Sendil Kumar, and all my other medical colleagues who have been doing yeoman work in telemedicine. Very good morning to all of you. I'm sure this is going to be a very, very important meeting, and I look forward to joining hands with all of you in the future also, because I think a lot needs to be done in the country. And when Dr. Manish Diwan was outlining the various 6 areas, I was able to see how closely every aspect of healthcare, whether it's primary or secondary or whatever, has been thought about. So on that note, I'm going to very quickly give you an overview of telemedicine in diabetes. And in fact, that's our, the one on the right side is our, in the Women's Biotech Park, our research center, about 40,000 square feet of built up space in Asia's largest standalone diabetes research center. Now, I'm going to be very brief, but I'll tell you, 2 or 3 areas, because in 10-15 minutes, I don't think I can give do too much of justice to this. But just to give you how important COVID has turned out to be in terms of telemedicine. Now, there are very many challenges in diabetes treatment. Now, when COVID-19 came, for the first few months, everybody forgot about the common diseases, common non-communicable diseases. And then, of course, COVID reminded everybody that, it is the people with the comorbidities, specifically diabetes, obesity, heart disease, and so on, who actually fare badly. So to me, COVID-19 was actually a wake-up call about the importance of non-communicable disease. Most other people seem to do well. For example, people were not able to go in the first round, especially people were not able to go to the labs. They could not get their blood tests done. There was no laboratory testing. They had not even got their glucometers out for a long time, and they could not go for a walk because of the lockdown. They couldn't get healthy diet to eat. Every aspect, and then of course all the false news and fears saying that you're going to die, you're going to die, you're going to die. And something like 30, 40 social media videos and engagements I had made just to tell people, well, you're not going to die. The number of people who have died are very, very, very few. So just don't worry about it. The statistical chance of you dying due to diabetes. And I'm happy to tell you, as I'm going to show you in my next slides, that out of the thousands and thousands and thousands of patients of mine who have developed COVID, hardly 1 or 2 have died. And those who were not poor people completely neglected and who had not come back for people like Sunil Shroff and Ganapati and many others have played a big role in developing this, and I have also been happy to be associated with them. But then once telemedicine came, we were one of the first to analyze, because at that time, various mathematical models, I thought this is very strange. How can HbA1c go from 16.8 to 16% just because you have a viral illness? So what we did was, this is one of the first papers at that time. By July 2020, we had already published it. We had done a study and published in an American journal, where we looked at what happened during lockdown and how did our patients do. Since we had patients all over the country, we reached out to all of them. And these were some of the states from which we had a fairly large number of patients, 2,510 patients whom we surveyed, and we asked them various things. Around that time, we also developed a model which may be of interest to you, because we said the doctor can't go to the clinic, the patient won't come to the clinic, and so how are we going to arrange this whole thing? So we had to very quickly put on a thinking box. And then what we did was, we said we'll have a call center. Patient calls a call center, which is directed to the dietitian or the educator, who decides what tests to do. And then the phlebotomy is done at the doorstep of the patient. And then the reports are generated in our lab. That report is sent to the consultant via into his mobile phone, because EMR can get linked to the mobile phone. And then through that, he then talks to the patient, who then decides about the consultation, and then the reports and the consultation, prescriptions, everything sent to the patient. And if medicines are needed, they can also be delivered to the doorstep. So you can see everybody is at home. The patient is at home, doctor is at home, everybody is at home. Only a few essential staff working in the clinic. But then the entire system is created. Now we want to see what is the impact of this, because remember I just told you that everybody has said that HbA1c is going to go to from 8% to 16%. That's the projection. Now just to show you how we did that, we maintained social distancing, fumigation, we went to people's homes. You can see that even there, they're all separated out. And this is the first phase during the lockdown, okay? And our nurses going home and taking the blood. And of course, they had a lot of problems. They tried to, many of them did not even try to see the doctor. They were so scared. And they had a lot of challenges in accessing the clinics and in accessing home delivery. There are lots of challenges which we first outlined. But then look at what happened. People who are not testing the glucose at all now took out the glucometer, because the fear of God was put into them. I always say that Dr. Mohan is very ineffective in putting the fear of God into people, but COVID really brought the fear of God into people. So you can see that of the only 15% of people who are testing their glucose, these are people who have confirmed diabetes, only 15% went up to 51.3%. That's more than a 3 times jump in number of people who tested, and the frequency of testing also went up. Now look at this. You know, the HbA1c prediction I told you, they said it will go up from 8 to 16%. And there are at least 6 papers in the world which have said, yes, HbA1c is going to go up. HbA1c is going to go up. We were therefore surprised, and we published this showing that the A1C actually came down by 0.5% because people are more careful. They started eating less. They said, I'm not going out for exercise, so why should I eat so much? They started becoming regular with their medicines. They got so scared that if their diabetes is not controlled, they'll do poorly. And therefore, thanks to telemedicine, we are actually able to show for the first time in the world, I think, a reduction in the A1C during the lockdown period. We thought this was really fantastic, and a tribute to telemedicine and to our patients who took such good care of themselves. And also reduction in weight and reduction in so many other parameters, totally unexpected at that time. 4 or 5 papers subsequently have confirmed that a lot of people actually did well. It's not that everybody did well. There are people who completely neglected. There are people who went into depression, all kinds of people. There's no one size fits all. But this is a fairly large series to show that you can actually show improvement due to telemedicine. But then is everything okay with telemedicine? Even at the peak of telemedicine, when people could not come, about 50% of them said, no, we don't like this telemedicine, talking on the phone. We are not familiar with technology. My son and daughter are not allowed, are not around. And so many other problems were there. They wanted video consultation, their bandwidth was not good, and so on and so forth. So there are a lot of problems. But about 50% of them were actually very happy. They said, look, we don't have to come to the clinic. We come and waste 2-3 hours there, 4 hours there. Plus I have to spend on transport. Here you're coming home. And of course, I'm glad that it was mentioned that by Mohana Shankar that actually telemedicine should be at a premium, because till now anything where you don't actually see the doctor and touch the doctor is considered free. And that's one of the problems with even social media or with emails or anything. People expect unless you actually touch them and take the blood pressure yourself, you cannot charge a single rupee. I think that has changed, thankfully, due to tele consultation. Now, the second part and a very brief part I want to talk to you about is that even before this telemedicine was legalized in our country, there was no choice but to use telemedicine in our country, which is so big and has so many remote corners where doctors cannot even go. And one such is rural areas. Now, it's very a little pathetic that while 72% of India's population lives in rural areas, 75% of the doctors still practice in urban areas. And if you look at the whole of diabetes, these numbers are now changed, but more than half of all people with diabetes live in rural areas where there is poverty, there's lack of literacy and transportation problems, and of course there's no specialized diabetes care facility. So how are we going to reach this to rural India? So we thought of this and we said we should make the 6A test possible. That is, make diabetes care available, accessible, affordable, appropriate, acceptable, accountable in rural India. There was no such model when we started about 14, 15 years ago, but we said somewhere we have to make a start. Around that time, in a village called Chunampet, which is in the southernmost district of Kanchipuram, which is the next district to Chennai, as you all know, a zamindar who unfortunately died recently, he was giving away all his land. So he called me and he said that I'm willing to give you a large portion of my land free if you do something for the poor people of Chunampet and surrounding villages. So that was born the Chunampet model for rural diabetes care. We got support from the World Diabetes Foundation Denmark and the Indian Space Research Organization, which gave us the satellite. Using this money, we built from scratch a large mobile van, and I know that Dr. Sheila John is here. They're doing very similar work. I know that Arvind does similar work. But about 14, 15 years ago, it was still quite new to have a literal mobile diabetes hospital going around from village to village. And this is the big satellite gifted to us by ISRO. And inside it, you had everything that was needed for a hospital. And so what we did was we went to villages like this, where we took local young men and women who were high school dropouts, trained them how to get informed consents, how to check the weights and how to check the heights, how to check blood pressure, how to check the blood sugar. Everything can be taught to them. Within a month or two of training at our center, these people were experts. And guess what? They already had a job. We thought it's a great example of Abdul Kalam's dream of Pura, that is providing urban amenities in rural areas. Now, if somebody like this lady has diabetes, all they have to do is to step into the van where not only the whole of diabetes can be checked, but also the eye, retinal photographs can be taken, which can then be sent back to our base center where Dr. Prathipa, our senior ophthalmologist, is talking to this lady in a van parked hundreds of kilometers away and telling her what is diabetic retinopathy and what is a lens and what is a retina and why we are doing it and why it needs follow-up. Now, we set up in the land given by the zamindar. My wife and I donated the money for the building, and the Sai Rural Diabetes Setup was started with Dr. Rakesh, who is shown here, and a doctor from that area who was taken, trained, and put back. And he continues to run that center for the last 15, 16 years. The results were remarkable. Not only Chunampet, but 41 other villages, the government of Tamil Nadu gave us permission to go and screen free of cost. Everybody who had diabetes underwent a thorough screening, not only for diabetic retinopathy, but also for neuropathy, nephropathy, peripheral vascular disease, coronary artery disease. And therefore, we got the first rural data on complications from any developing country. And then using very low-cost drug treatment, a few paise that the drugs cost, the A1C of the entire population was brought down from 9.3 to 8.5%. It is a remarkable achievement, which I don't think anywhere in the world in a rural area had been achieved. And therefore, the Lancet wrote about it, and they said the Chunampet rural, this is an article on 5 articles on India, which was published in 2011, where they picked the Chunampet rural model, and they said Chunampet Rural Diabetes Project that seems to be a good model for developing preventive and therapeutic healthcare in rural areas. Look at the date, it's 2011. It's almost 10 years before COVID, we even thought of COVID. Here is a full project rolled out in rural areas of India. The CNN, Discovery Channel, Le Monde, the French newspaper, BBC, and several business magazines all wrote about this. In the book Jugaad, there's a whole chapter devoted to the Chunampet Rural Project. So this is a demonstration project. I'm happy to say that the project, the rural project, is still continuing 16 years after we have no funding from the World Diabetes Foundation, which gave us only 3 years. We made it a self-sustainable model, and it has worked very well. We are now extending it to many more villages in rural Tamil Nadu. So, ladies and gentlemen, I'd like to stop here in the interest of time to tell you that telemedicine is an excellent tool for treatment of diabetes during COVID-19 and therefore for future pandemics, which heaven forbid may come to our country. Patient satisfaction telemedicine was high among those who accepted it, but 50% preferred face-to-face consultation. They still wanted the touch and feel of the doctor. There are several challenges for the use of telemedicine, including bandwidth problem, people not being technology savvy, etc. But these are all problems which you can expect when you use any new technology, and these will evolve with time. Using telemedicine, it's possible to reach out to remote rural areas of India, as shown by Chunampet Rural Diabetes Project. In fact, one of the big learnings for me has been that in many states of India where we do not even have branches, including Maharashtra, Gujarat, and many other places in the north of India, I'm now regularly getting patients for telemedicine who otherwise would have been denied the opportunity because A, we don't have a branch there, and B, it's difficult for them to travel. So I would say, as far as my specialty is concerned, which is continuous follow-up, telemedicine has been a complete revolution as far as care is concerned. Thank you.
Thank you so much for joining us today, sir. Thank you for sharing your knowledge with us on the diabetic population and also about the impact of telemedicine on diabetes. Thank you so much. It was great having you here with us.
So, any questions I'd be happy to take. I can't see
any queries from the participants?
Thanks, Mohan.
Hello.
Yes. Yeah, go on.
Sunil,
go on. Yeah.
The Chunampet project, which you had, were you able to also look at prevention from the angle of, let's say, you looked at nephropathy, you looked at microalbuminuria and so on. So did you actually look at, perhaps, I don't know if maybe it wasn't focused towards that, but kidney failure in diabetics, were you able to get some data on that?
We got the cross-sectional data, Sunil, because it was bad enough to do it once for an entire population, for several thousand people who had to be screened, almost 50,000 population. So in the project itself, we got the first baseline cross-sectional data. We now have longitudinal data on the incidence of kidney disease and so on. But we very well know that a 1% reduction in the A1C translates to a 25 to 33% reduction in retinopathy and nephropathy. That's very well known from DCCT, UKPDS, and so on. Since we showed almost a 1% reduction, we almost sure that this is happening. But we do have serial follow-up record at the Chunampet Center. It could be a little biased because the whole population doesn't come to the clinic. Only those who come for follow-up are there. But we are able to show demonstrable changes in both retinopathy and nephropathy over a 10 to 15 year period, which we hope to be able to publish this quite soon.
I think these are the examples, which should be enlarged and magnified multiple times in the country. And, I think, remarkable work, Mohan. Congratulations again.
Thank you, Sunil. Thank you so much. Sheila, you're muted.
I have a question.
Go ahead.
Hello.
Anybody? Yes, Pranav, go on.
Yeah, hi, good morning, sir. This is Pranav from Rajkot, Gujarat. Sir, I'm from engineering background and I'm planning for my startup in healthcare sector, which includes telemedicine as a part of it. So, sir, my question to you is, you mentioned that people were, they were not willing to go towards telemedicine initially. So, how did you enable them and how did you make them cross this transition barrier to come to telemedicine? And once they came, so you might have also noticed, then they must have felt, we should go for physical ones only. So how did you retain them?
So good point, Pranav. See, when the lockdown first started, people thought that it's going to be for 2 weeks, 3 weeks, and then it's a passing phase, cloud. So we can, then go on later on and so on. But as time went on, and they found that, the fear of, COVID, people are dying, most of them are diabetic, this, that. Then when we reached out to them and said, look, you don't come, but and they're scared to come to the center. There are people who had gangrene who would have died. In fact, one man died also. He still said, I don't want to die due to COVID. I'll die due to this gangrene, but I don't want to die due to COVID. That's the kind of fear people had. So eventually people said, oh, this is a good thing. They are coming home. They're taking precaution. They're wearing gloves. They're wearing masks. So probably it's okay. But the people who still could not accept that those are not techno-savvy. They can't even make a phone call with their phone. So now to get into telemedicine, and many people want video consultation. So the bandwidth is not enough. So these were the problems that the people had, and they can't hear. You call them, yeah, what did you say? What did you say? They're hard of hearing. What do you do if you're hard of hearing in this? Whereas here, when you're lip reading, it becomes much easier in a clinic. And of course, for some of them, it is like a picnic. Once in 3 months, coming to the doctor. They have the retired people coming and meeting the doctor patting them and saying, hey, you did well. That's what they want. That physical thing and that personal touch is gone once you have this. But I'm sure with all the, VR technologies and everything that you guys can come up with, you youngsters, it will become virtual reality. And so I'm sure all those things Pranav, you can solve it for us. Incidentally, my grandson's name is Pranav. So,
oh, great, sir. Right. Thank you, sir.
Sheila,
I have one more. Sir, if you allow, I have one more part to it.
Can we just wait, Pranav? We'll finish others.
Sheila, yeah, sure.
You're muted, Sheila. I'm not able to hear.
I guess there is some issue with Dr. Sheila's mic. I'll just speak with her and I'll
okay.
check that.
Hello, sir.
Now, who else? Go on.
Yeah. Sir, is it hearable?
Vikas, go ahead.
Hello?
Yeah, Vikas Verma, go ahead. You're also muted. Please unmute.
So what was the turnaround time? Like you were able to see sufficient patient with this telemedicine, or like you were able to
thousands of patients. We have reported on about 700, 800. That's because we wanted to be the first to report in the world. But subsequently, it's thousands. But then, as the lockdown lifted, as people started coming back, medicine went down, and face-to-face increased. Today, it is restricted to those who are not able to immediately come. Somebody in Chennai will not prefer telemedicine unless they're scared now. After Omicron, again, they're scared. Otherwise, they'll say, no, I'll come and see you at least or something. But suppose there's somebody in Mumbai or Gujarat or somewhere else and they want to consult, they are not able to come immediately. Take a flight and immediately come. The cost goes up so much. Whereas we'll say you get all your tests done there. These are tests I want. And then we'll have a video consultation. That's as good as if they've come here. So it's opened up new vistas completely. And there are people from Dubai and other places also, who cannot suddenly come, but who want to consult something. They'll say, when you come to Chennai, we'll come and see you. But before that, I have an urgent problem. Can you help me with it? So things have changed a lot. Probably a hybrid situation, I think, will settle, because when you need 3-4 visits in a year, maybe once a year they will come, or once in 2 years they'll come from somewhere very far away. And the rest of the time they can have 2-3 consultations through video or teleconsultation.
Audible?
Go ahead.
Is it audible, sir?
Yeah. Sendil Raja, go ahead.
Yeah, yes, sir. Sendil Raja.
Yeah.
Sir, I have a question. This telemedicine is by making the phone to the patient, just to what are the problems we have. Whether the patients are, by using this telemedicine concept, whether the patients are following what doctors are exactly saying.
So because see, it's always followed up with a printed out prescription and an email which explains everything, because I might have said something the person may not have heard. So normally what I do is everything that I told them I repeat in an email. We discussed about this, then I told you to do this, let me remind you that you have to do this, because they'll forget. They're not taking notes, you know. So a follow-up email will tell them everything, 1, 2, 3, 4, 5. Here is your prescription. 3 months later, meet me with these following tests. Everything is laid out to them. Only thing they have not met me. So to that extent, the follow, as I showed you, the results actually showed that HbA1cs came down. What more do you want? Weight came down. HbA1c came down. I mean, unbelievable, unexpected results. So when we got it, we quickly published it. We thought somebody is going to reject it. But people said, hey, this is something very different. They're talking about 8% going to 16%. You're showing 8% coming down to 7.5%. You know, this is something very new. So I think it will work to a large extent.
But you are giving through mail, but most of the people in the rural areas. But how the rural areas
it will be delivered to them. We either send it through mail or through post.
Okay.
Hard copy will go to them.
Okay, thank you.
And most people, you know, even if they don't have, their son or daughter or somebody is there in IT, everybody has some access, and so somebody is helping them at home. Sheila, your question.
Yeah, somebody must be there like that. Otherwise, how the older people are uneducated.
Correct. No, they have support. The sons, the next generation is always there. Yeah. Oh, yeah. Sheila, you want your question?
Initially, all of us started with Indian Space Organization's satellite connectivity. Yeah. Even we had mobile vans with satellite. But later in 2012-13, we shifted to internet, and by 17-18, it is internet. Are you still using satellite connectivity?
No. That WAN still has it because we couldn't remove it from the thing. But technology has changed so much, and it's much less cumbersome nowadays to do it. The bandwidths have increased. So we are not using that now. The videos I showed you were 15, 16 years old, as you rightly said. I think I've taken a lot of time. Other people must be waiting. So
thank you so much, sir. Thank you so much.
And the organizers.
So thank you, sir. We will have a full session with Dr. Mohan for all those who have questions lined up. We will definitely have a session with sir. Thank you so much all for. Thank you so much, sir. Thank you all for your questions. So moving on to the next part of the session, we are starting with a panel discussion. So the next panel discussion is on telehealth practitioners' perspective and patient experience. So to moderate the session, I would like to welcome Dr. P. Sendil, founder and CEO of Wellcare Health Systems Private Limited. Dr. Sendil is an ophthalmologist and healthcare entrepreneur. He's also the founder of Ophthalm Practice Development. He's also the director at Pranav Eye Care Hospital. As an ophthalmologist, Dr. Sendil understands the importance of staying in touch with ophthalmology and ophthalmic community to get insights and networks which help in development of other ophthalmic enterprises. Over to Dr. Sendil to introduce the panel members and start with the session.
Yeah, am I audible?
Yes.
Yeah, thank you, Mr. Muthusingaram sir, for putting up this interesting program. And thanks to all my friends, especially thanks to Dr. Mohan and all the key panelists of the session. I think a very interesting session today. The physician's perspective and the patient's perspective. I think these are two interesting perspectives. How does a physician think of telemedicine? Just before we heard about Dr. Mohan's perspective on telemedicine, how he used it for his patients during the COVID, and then more important, not to be forgotten, is the patient's perspective. How do patients perceive telemedicine? I think we will be having a very interesting session, and three interesting panelists. Professor Ganapathy needs no introduction, though I don't like to say this word needs no introduction, but definitely sir doesn't need any introduction. He was the person who brought me into the telemedicine thing itself, and he is the director of Apollo Telehealth Services. Dr. Dheeraj Krishna, known to me for quite some time, and he is the head of telemedicine at Star Health Insurance, which is one of India's leading health insurance companies. And Dhruv Joshi, he is the CEO of a company called Cloud Physician. And I think we have a very interesting panel, a neurosurgeon, doctor who works in insurance, and a technology person. So basically, I would request each of the panelists to just have a small introduction about yourself, and then we can go ahead with the questions. I would request Dr. Ganapathy to self-introduce himself and also the topic, and then we can go on to Dr. Dheeraj.
Thank you, Dr. Sendal. You're able to hear me?
Yes, yes, sir. Yes, sir.
Okay, fine. First of all, I belong to the BC era. I'm not talking of before Corona, I'm talking of before computers. I was the last neurosurgeon in this country who was trained even before computers came into hospitals. So though obviously I love technology, have some idea of technology, I believe, and I'm very concerned in one way, that whether it's 2022 or 2030, medical doctor, now the word doctor is replaced by a healthcare provider because others are also providing healthcare. I very strongly believe that our primary reason for our existence is to provide tender, loving care. Technology or no technology, we need to understand that technology is a means to achieve an end and not an end by itself. And of course, the telehealth has grown up enormously, maybe 10x, maybe 12x in the last 2 years. But this behavioral modification, as I call it, has been necessitated. It has been on, etc., etc. Primarily, it was not so much by choice, but because we were forced to do it. Now, I very strongly believe that if telehealth is to become an integral part of the healthcare delivery system, and I would be the happiest person if in my lifetime there is no need of a telemedicine society of India. I mean, this statement may look absurd, but what I mean is we have no stethoscope society of India. Everybody uses a stethoscope or used to use a stethoscope. Similarly, telemedicine at this point of time is, unfortunately, according to me, a separate group of passionate people who are trying to promote it. But the day should come when telemedicine is a part of every single discipline, telecardiology, teleophthalmology, teleneurology, teletrauma, blah, 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 etc. In other words, we make distance meaningless and we make geography history using technology. For this to happen, today's younger doctors particularly, we are amazing plumbers, amazing carpenters, amazing electricians, the skill with your hands, you are able to enter a branch of the middle cerebral artery and things like that. But somewhere along the line, we have somehow lost or given less of importance to what the patient wants. And one thing very with the telemedicine practice guidance of India is it repeatedly mentions ad nauseum that everything is contextual. We need to understand the rules, guidelines. I always tell people for the last 22 years, I've been telling them, I will be the happiest person if there are any cases filed against doctors or whoever it is on the malpractice or somewhere involving telemedicine. Please do not worry about rules, regulations so much. They are only guidelines. It is contextual. So what is most important is you need to get into the mind of the beneficiary. This is very important. You cannot have a customized, I mean, protocols are good. It's very nice to have guidelines. It's very nice to have do's and don'ts, etc. But these are, as the word implies, just guidelines. Ultimately, it is you and you alone who take a decision on whether to use telemedicine. What do you mean by telemedicine? When do you stop? When do you insist on a face-to-face consultation? How do you bridge the gap? Dr. Mohan mentioned just a few minutes ago, he was saying, yes, a 75-year-old diabetic has got a normal age-related hearing problem. How do he is not able to understand what you are saying in the first instance. It is not because of bandwidth problem at all. And my grandchildren are much more competent than I am in using a smartphone. So technology does have limitations. So my take-home message would be, please use technology in a contextual way. Spend a few minutes listening to the patient. That is all that he wants. particularly the older patient, particularly the patient with a very, for you, it is an HbA1c of 9.1. But for the person with diabetic neuropathy, he is not able to walk, he is not able to fit his foot into his slippers, etc. Please listen to him. Sir William Osler said 170 years ago, he said, listen, listen, listen. He is telling you the diagnosis. Unfortunately, the world has changed completely. We have all become adept at EMR and hospital information system, personal health record. We spend, like the American doctors, we spend 20% of our time in filling up forms and pro formas, etc., etc., etc. What is equally important is just listen, clinical examination. There are doctors who will still insist on a rectal examination to find out if prostate is enlarged or not. My student is much more competent using a 4D pelvic ultrasound, where he will using a Doppler, where he will even know the blood supply to the prostate. He does not want to do a rectal exam. Absolutely fair enough. But don't condemn me because I am old-fashioned and I want to do a rectal examination. So please remember, it is contextual, banking's online. Why? Because Amazon has packed it in such a fan, they get excited about it. Similarly, please excite. Please excite beneficiary. Make him feel that for this next 5 minutes, the only reason for your existence is seeing him use technology to make him understand that you and alone, he and he alone is your end. I may be old-fashioned, but clinical medicine is dying. Clinical medicine should be revived using technology. Sendal, I deliberately chose a topic which I thought the other panelists may not cover. I mean, there are enough people to talk about medico-legal, about bandwidth, about business model, about what to do, what not. But this is one aspect I thought I should emphasize. Thank you.
Yes, thank you, sir. Thank you. I think after you speak, it becomes very difficult for all of us to talk. Now we are all anxious. So maybe to go on with the question. So I would like to request Dr. Dheeraj to, because initially during this COVID, when the COVID pandemic started, the volume of teleconsults was very high. Like everybody was seeing hundreds of patients and everybody was very hyped up about it. But once things became normal, I think, particularly in ophthalmology, there was so many people who, because they were not able to go to hospitals and doctors were not able to go to the hospitals also. So the volume was very high. But right now we are seeing that many hospitals started teleconsultations, have stopped it. And what do you see about the volume, particularly in an insurance point of view? Because I think your teleconsults are also free. So how is the volume during the COVID and when things are normal? Dr. Dheeraj.
Thank you, Dr. Sindhu. Thank you for the question and thank you for the wonderful introduction. And I would like to thank Dr. Muthu for organizing this event and all my predecessors in the field. Thank you so much for organizing this platform. I think, Dr. Sendil, what you had pointed out was something which is very valid. At the beginning of the pandemic, probably sometime mid-2020, right, we saw a huge peak in the number of teleconsultations. And as you are aware, we also got the government's regulations on the practice of telemedicine. We also saw a lot of hospitals come forward to develop the practice of telemedicine. But I would not say that today we are going down. I would say that we are plateauing rather, right? We are not seeing a downwards trend. But what happened at that time when, mid of 2020 was people were not aware of the concept of telemedicine. So they were early adopters and they were, fascinated by the concept rather. Everyone tried it out. But today people know what is telemedicine and what are the limitations of telemedicine and what are the benefits of telemedicine as well. So what we are seeing today is it is plateauing. And as Dr. Mohan had pointed out, I think the more we see telemedicine, I would say the concentration of our telemedicine calls or consultations are from the rural area. And that's what we want as well. Right? Today, we are at an urban center, we have access to specialists and super specialists. Whereas we wanted the penetration in the rural area. We want healthcare for all, right? So we are seeing that. And I would suggest that's a good thing for us as a telemedicine fraternity, that we are seeing there's an adoption from the rural area. So that's my point on that, Dr. Sandhu.
Yeah, thank you, Dr. Dheeraj. Dhruv, can you, maybe you can introduce what exactly you do about your company a little bit, and then maybe you can also take up this question on the volume of patients during COVID and post-COVID when normalcy has arrived.
Thank you, Dr. Sandhu. And again, it's a pleasure to be here on this panel and be along with my esteemed panel members. Just a quick background about myself and the company that I run, services to hospitals. Started this company in 2017, and it's now coming up on 5 years that we've been running Cloud Physician. What we provide at Cloud Physician is that unfortunately, the status today is that high quality critical care remains the domain of a few centers, large tertiary care centers, and perhaps some of the more corporatized centers at urban locations. Unfortunately, the need for critical care is far and wide in every community, and every community hospital needs to have be able to provide quality critical care to its community members. And at Cloud Physician, Ladakh to Silchar Valley in Assam to Kerala to rural Gujarat, the community hospitals where we have a command center, we have a technology platform that connects these hospital ICUs to our center so that our team of super specialists who are available 24/7 can oversee the management of these patients far and wide across India. Obviously, this was a problem that is widely prevalent and one that we were solving far before COVID. Like I said, we started the organization in 2017. But with the onset of COVID, the need and shortage of high quality critical care was very apparent. And in that period, to Dr. Senthil's point, we saw a huge surge of patients across both the private hospitals, government hospitals, where we were called on to help augment the teams at the bedside and help them ensure that the quality care can be delivered. My comments on this topic and the way that I sort of envision this, I was talking to somebody just recently at a large corporate hospital, and the person was the head of operations at that corporate hospital, and I was asking him about his ICU, and he told me that, hey, you know what, our ICU is great. We have a team of 50 very highly trained critical care nurses. We have 9 highly trained intensivists at this hospital, and we're able to provide quality care. And it just sort of reminded me. I used to be at a hospital. I was at the Cleveland Clinic. That's where I trained and worked for many years in the US. And we used to have 150 critical care specialists, intensivists there. And we used to have hundreds of critical care nurses, and as a result, we were able to provide perhaps higher quality care than most other places in the world. That model is simply not scalable. Right? You're never going to, if to provide high quality care is going to require 150 intensivists or 10 intensivists to be in the walls of one location. We're never going to address the public healthcare needs of the country or the world, because that is not a scalable model. There's not enough money in the world to pay for that kind of healthcare. There are not enough people in the world to deliver that kind of healthcare. So if we are going to look to scale high quality care, we need to find a model that does not depend on just having huge numbers of highly trained specialist doctors everywhere, wherever they need to be, because that's not going to be possible. And that's our vision at Cloud Physician, has been to create that model, to use technology to streamline the way that hospitals work and to be able to provide the same quality of care. And we measure that care and bring it with to Dr. Ganapathi's point, with the bring that delight to the user, whether it's a doctor or a nurse or a patient or a patient's family member. And I think we have found some early success in this. We measure the outcomes of patients in the hospitals that we support, and I can tell you that, for example, we have a small hospital ICU in Nadia. There is an area in Gujarat, about 2 hours from Ahmedabad. The hospital ICU is completely digitized. It's paperless. 24/7, our intensivists oversee the care of those patients. Our intensivists are based in Bangalore. There are more junior nurses and doctors at that location, and we have trained them. We provide them with ongoing training. We provide them with support. We're able to see exactly what's happening with those patients in real time, respond both proactively and reactively. And when we measure the outcomes of the patients, and if you were to look at the quality metrics of the patients in that hospital in Nadia, Gujarat, it is as good as any hospital in Bangalore today. A model that can address that need and provide access to high quality care accessibly, affordably, cost effectively. And the only way that we will do it is by leveraging some of the telemedicine platforms, leveraging some of the technology platforms that we have. And I think telemedicine in and of itself, when people think about it, they generally think about, having an app or having a phone and calling a doctor. But what we're going to find is that telemedicine is a very, very wide basket of entities, and within telemedicine, you're going to have different forms of telemedicine. For example, what we do is different than what a player like a Practo or an MFine would do. We support hospitals. We enhance the capability of hospitals that aren't able to provide high quality care to their communities. That's one form of telemedicine. So similar to this, you're going to find many different streams of telemedicine that are going to emerge. We do it in the high acuity space, in the critical care space. There are others that do it in the primary care space. Then you will find more and more such entities emerge. I think it's an exciting time.
So maybe I would also like to give a small introduction of what I am doing. So I was a regular ophthalmologist, practicing ophthalmologist, say 7-8 years back, seeing say 20-30 patients, 50 patients every day and doing surgeries. But I always understood that this is not something scalable. Though how many patients can a doctor see in a day, or how many surgeries a doctor can do in a day. And I was seeing this diabetes problem. So there are almost 70 million diabetic patients in India, and there are only say 18-20,000 ophthalmologists in India. So it's literally impossible to wait for all these patients to come to ophthalmologists. And the incidence of this diabetic retinopathy is 1 in 4. So what I thought was, instead of waiting for the patient to come to ophthalmologist, why don't we do a way where we can actually reach out to the patient? So we started, I think I started our company in 2015, and basically we work with the diabetes centers, smaller ones, not larger ones like Dr. Mohan's, where there are ophthalmologists available, doctors who do the screening and we give the reports back to the patient. So over the last say six years, we have screened almost 2 million patients. So as an individual doctor, I think I would not have reached the number of 2 million individually. How many patients can you see? Even if you see 100 in a day, 2 million is not reachable in my lifetime. So but only issue is this, though we have seen 2 million, the population to be addressed is 70 million. So we feel there are a lot more players who have to come into this field and get the screening done. So okay, so getting back to the panel discussion, I would like to talk about the perspective of the patient. So how does the patient perceive a teleconsult? They see, because in our ophthalmology field, what we understood was patients are okay to do teleconsult, but they're not willing to pay for it in a regular practice. I think maybe Dhruv, because you are in the ICU intensive area, I think this problem might not have been there. And maybe Dheeraj has been working with the Star Insurance. So for them, this issue is not there, because I think they provide it as a value-added service to the patient. Maybe Dr. Ganapathy sir, can you comment on the willingness to pay? Because initially patients were a little bit offended when we asked them to pay for a teleconsult because they thought it's something to be done for free.
That's a very important topic which needs to be addressed. Unfortunately, we have been overseeing telemedicine is very rarely a single payment. So we do almost of Apollo services public-private partnership. I think that is go. So that does not pay directly to the consult at all. The government, we have 8 governments now. The government outsources a small chunk of either a specialized practice like ophthalmology or a general healthcare. For example, in Andhra Pradesh, we have 183 primary health centers where we see on an average 100 to 100 persons every single day in each PhD. Now they outsourced it to us 5 years ago. We totally did everything. Now we made it because of excellent, outstanding management, etc. There was a slight excess of income over expenditure, not profit making as the rest of the Apollo hospital would be. And you should never know, and I'm very sure of what I'm talking about, should telemedicine be viewed as an intensively ROI, return on investment return? No way. But if you are satisfied with a return of 10%, 8%, 11%, something like that, then I think this is eminently doable. So it is a major. The other thing is, of course, the review cases. 80% of our consultations in the Apollo system are review cases. It looks the patient does not mind spending some money because he's spending only 10%, 15% of what he would have had to spend if he had come all the way from northeastern India to Madras, see a cardiac surgeon for a scar post-operative. So I think it differs entirely, but I think Krishna is
there's 2 types of telemedicine. I think the advocates of telemedicine in India would always talk about it. One is the commercial model and the first initiative, but adopting to the first initiative. I don't know, the government's national digital health mission might probably pave away affordability among the hospitals, because today, let me say, when you go to one hospital and move to another hospital, you always carry your prescriptions and things on a hard copy. But that does not stay the same with teleconsultation, because not all platforms allow people to download their prescriptions and share it with the other doctor through another telemedicine app. So there are limitations on that front. I would suggest creating and working on creating a more holistic ecosystem, including e-pharmacies, including lab tests and all those things together, and refining that would help in a wider adoption.
Dr. Dur, any comments from your side? I think my question was on what should be the platform's role? Platform should enable a physician, or platform should also try to get patients to the physician and charge a fee? What is the ethicality on that?
Yeah. Thanks, Dr. Sendla. I think, to Dr. Dheeraj's point, I sort of agree with him in that this ecosystem needs to form, to become a little bit more mature. What I would say is that, if you were to look at the field of telemedicine that's been around the longest and perhaps the most advanced, I would say perhaps be teleradiology, right? It's been around for a long time. People are doing it. It's widely prevalent right now, and I foresee a time not long in the future where there is no such thing as teleradiology. No one will refer to teleradiology as radiology. It will just be radiology. Right, that's what you're going to see. You already see it. Every radiology center, every hospital is using some component of what quote unquote teleradiology, and perhaps in the next 5 years, the term itself will not be used, because there's no such thing as teleradiology. It's just radiology, and that's just how radiology happens. So I think while other fields of medicine will perhaps take a few years to evolve to that level of maturity, but that's generally the direction that we will see this entire convergence of tech, where it sort of gets more and more entrenched and more just part of the way that we do things. To Dr. Ganapathi's point, it's always going to be contextual. It is always going to be contextual. As long as you're clear about what you're doing, you're improving the patient outcome, and you're improving the experience of the patient and the user. As long as we're aligned that that's the direction that we're going to move in, we will see many applications of technology that will allow us to move in that direction. Right? To your point, platform versus provider part, I think again you will find some form of a convergence there. There will obviously always have to be checks and balances, from a regulatory and ethical standpoint. And then I think that people are working on this as we speak. I only hope that they can evolve these regulatory parameters as quickly as the innovation is going to take place, which usually never happens. But let me just say that at the end of the day, if we are going to look again, to use that term, look at making quality healthcare accessible at scale, it would have to have a viable business point, right? I don't see us being able to enable access to high quality healthcare at scale for entire populations without there being a sound business model around that. But for example, some of the work that we are doing, where we're already finding that there are business models that are sustainable, that can ensure accessibility to high quality healthcare. And when I say accessibility, I mean accessible as well as cost effective and affordable. That's the only way that things can be accessible. Doesn't help if you are accessible in a place, but you can't walk into that building because you can't afford it. That's not accessible. Right. So I think there are different components of accessibility, whether you speak about it in terms of tier 2, tier 3 or rural places, or whether you talk about it in terms of urban locations. High quality healthcare should be accessible to everybody living in urban locations as well. It should not be the confines of 2 or 3 hospitals, the ivory towers in 2 or 3 cities. It should be accessible to everybody, and we will have to create business models that enable that accessibility.
So I can see the moderator. I think we are near the completion of the session. Maybe if, one question from the audience. I think Nilanjana Chaudhary had a question. So Nilanjana, you can ask your question, and then we will complete our session with the question.
Good morning, everyone. I'm audible, I guess.
Yeah. Please go ahead. Yeah.
Good morning, everyone. I'm Nilanjana Chaudhary. I have a small software company called Medtech, and we are working on medical informatics. That is a project I'm working on, and I'm also associated with this HTIC. What we are trying to do is create a software that does without intervention of a doctor, tries to give a preliminary diagnosis idea that this person is under this problem, and then you refer the person to the doctor either via telemedicine, and in certain critical cases you have to take the person straight away to the doctor. So in this model we are working. While hearing your discussion, what I could rather gather is that we need to have this technology part and the medical part. The experts in various fields, we need to create certain kind of network, coordination, so that when my software indicates a certain problem, along with the rationale, I mean, on what basis.
In the interest of time, can you ask your question? I think it's important that we
maybe.
Okay. What is the way of? My question is, maybe I have explained what I wanted to do. So, what is the way of creating a networking with a lot of players are here we are talking about. So what is a way of coordinating with you so that we can create a network of doctors and so that we can address the remotest patients?
Yeah, I think that is what is the idea of this HTIC. This session is trying to create this collaborative ecosystem, and there is a Telemedicine Society of India, which also works together with all the different players. So there are lots of organizations which are trying to create this collaborative ecosystem. I think it will take its time. I think we are on time. Thanks to all the panelists.
May we have any comprehensive list of such organization or things like that so that we can contact them?
Yeah, we will be sharing it. We will be sharing it. I would like to thank all my panelists, Professor Ganapathy sir, Dr. Dhruv, and Dr. Dheeraj for a very informative session. And I would like to hand it over to the moderator to take for the next session.
Thank you so much, Dr. Senthil. It was a great panel discussion. Thank you for chairing the session. It was a great panel to know about the impact of both telemedicine and technology in the life of people, and also about the advantages and the few milestones that telemedicine has to overcome. It was a great session. Thank you so much, all. So moving on to the next part, we have the startup demonstration. So we have with us Swast Chain from HTIC to give a short introduction about his product and show a demo. Over to you, Sirish.
Thank you. Hi, everybody. I'm Sirish. I'm the founder of Swast. And today I'm just going to speak about what we do at Swast and the benefits of Swast. So I'm just going to share my screen really quickly. Yes, I hope it's visible. At Swast, we are an interdisciplinary team of the best doctors, technologists, and healthcare experts with the vision of bringing affordable and accessible healthcare into every home. We do this using our two apps, Swast Circle and Follow app. So using Swast Circle, we provide affordable and dedicated pocket hospitals to patients. Patients can subscribe to Swast Circles for a small subscription fee, similar to your Netflix, Amazon Prime subscription. And a Swast Circle is like a pocket hospital for you and your entire family. So each pocket hospital will have one dedicated family physician who can be contacted for anything at any time and anywhere. And a Swast family physician is basically a friend in need. Because our aim at Swast is to provide one doctor to every family. We want every family to have one doctor that they can contact immediately for any health queries that they may have, or they may generally Google. Because, you know, Googling for health information can lead to a lot of unnecessary stress and false information. The pocket hospital will also include 17 other doctors across all specializations, which include oncologists, cardiologists, psychologists, neurologists, and basically every other specialization you can think of, who can be contacted in just a single click. In order to improve the health dialogue between doctor and patient, the family physician also engages with patients on a regular basis, so they're up to date on the patient's medical history to protect them from unnecessary health risks. At Swast, we're trying to democratize healthcare and enhance the dialogue between patient and doctor. Nurses, home x-rays, home blood tests anywhere in India can also be booked directly from the app. Medications are also directly delivered to the patient's doorsteps using the Swast app. Every subscriber also gets a personal health assistant who can be used to book surgeries, hospital beds, schedule in-person and online appointments. So basically, Swast Circle is like a hospital that you can use anywhere, anytime, and for anything. We're already empowering more than 2,000 plus households, just this pocket hospital. Follow-up is a pay-per-use tool to automate post-discharge follow-ups, because one of the biggest problems doctors face is retaining patients. However, the ultimate success of a patient's treatment lies in its follow-up. Using Follow-up, our simple and effective app, a doctor never has to miss a patient's review. All the doctor has to do is create a follow-up plan for a particular procedure or surgery, or they can choose from one of the templates that we have available. A follow-up plan will consist of the number of follow-ups that may either be a video consultation or an outpatient appointment. The plan will also include what to expect during each follow-up. And if doctors are working in a group practice, they can also add their colleagues to these follow-up plans. Once the plan is created, patients can scan the doctor's QR code and subscribe to the plan. Patients can either choose to subscribe and pay for all the follow-ups upfront, or they can pay for each follow-up before the follow-up appears. As soon as the subscription is done, the Swasth Genie will actually book the patient's follow-ups on the days and times when the doctor is available. So the Swasth Genie will check the doctor's calendar, and based on the availability will schedule appointments. Post which, the Genie actually creates a personalized handbook for the patient, which you can see on the left side. So this is how our handbook looks, and will also set reminders for the patient. Using the handbook, patients can understand the rationale behind treatments and what to expect during their follow-up. 2 days before the follow-up and on the day of the follow-up, the Genie will actually remind the patient about their appointments. Follow-up can also be used to create an effective communication channel between patient and doctor. Patients can contact doctors using the chat box if they have any queries regarding their post-procedure care. Most patients are anxious post-surgery and tend to Google any questions they may have, leading to a slower rate of recovery. Using follow-up, they can contact the doctor and their colleagues at any time and avail video consultations if required. Follow-up can also be used to manage outpatient departments with ease. For example, prescribing electronically or managing a virtual queue. Something very cool about follow-up is doctors can also create personalized follow-up plans for patients who have undergone surgeries or procedures even 2 to 3 years before to get the same patients back in the loop. So what's unique about follow-up? According to a survey, 30% of patients do not appear for their follow-ups. Retaining patients is one of the biggest problems hospitals or doctors face post-discharge. Using follow-up, patients will subscribe to a follow-up plan, which will remind them about follow-ups. Every surgeon will have a system in place to follow up on patients that generally do not schedule their next appointment before leaving the medical establishment. The cost of missed patient appointments are very, very high. Estimates expect to almost be $150 billion annually. After the patient subscribes to a follow-up plan, the Swasth Genie will automatically schedule all the upcoming follow-ups based on availability. The Genie may book a teleconsultation or a clinic appointment, phone call reminders, and help to automated reminders. Patients will be reminded for their follow-ups, understand the rationale for the recommended return visits, the presumptive diagnosis, the next step of follow-up, and signs or symptoms to watch for just by using the app. Using a combination of telemedicine and in-person clinical follow-ups will lead to a more efficient workday and allow doctors to see more patients. Following a proper follow-up schedule reduces the rate of hospital readmissions by 40%. This in turn really improves patient satisfaction. At Swasth, we work with more than 250 plus doctors to make healthcare accessible and have impacted more than 3,000 patients to democratize healthcare. If anybody would like to learn more about Swasth, the services we offer, please feel to reach out to me via email. Thank you.
Thank you so much, Suresh. Thank you for joining us today.
Thank you.
So next we have with us Terralumen Solutions from VITTBI. Jyoti, are you there?
Yeah, hi, I am there.
Please go ahead.
Okay, thank you. I'll share my screen. Let me know if my screen is visible to you.
Not yet.
Hello?
Not yet.
Okay. Yeah. Is it visible now?
Yes. Please go ahead.
Yeah. Hi, good morning. I'm Dr. Jyoti. I'm the founder of Terralumen Solutions Private Limited. That's India's first terahertz company. Our aim is to transform the way world diagnoses cancer margin using terahertz technology. So this is the team. Myself, Dr. Jyoti and Dr. Somik have started this company. I'm the founder and is the co-founder of the company. We have Sonia and Lenin who are working as software embedded developer in this company. We have Dr. Bala Pesara, he's a technical mentor, and Dr. Syam Sundar Mandayam. Dr. Bala is also an assistant professor at IIT Jodhpur, and Dr. Syam is from GE. And we have clinical mentor Dr. Anurag Mehta, Dr. Juhi, and Dr. Bhanupriya from Dr. Mehta's hospital. So this is a complete team. So the problem statement, we are working on mainly breast cancer and oral cancer cases where we know cancer surgery is the important modality for cancer margin detection. 30% of the cancer surgeries fail due to inaccurate margin detection, which is 30,000 repeat surgeries per year. So when doctors will remove the cancerous tissue, they will remove extra amount of healthy tissue, which is called negative margin. But in some cases, since because there is excess amount of tissue we do not have, so with some amount of tissue left out in the body, that's called positive margin. So this is the problem because we do not have any device available for real-time cancer margin detection during surgery. And the current process is frozen section analysis and histopathology is post-operative and time-consuming as well as cumbersome. So we at TerraLumen have developed a compact device which will reduce the number of surgeries significantly. It's completely safe and accurate, non-invasive and non-ionizing technology. We are combining Terra with AI, which will improve the sensitivity and specificity. The decision is based on real time. Doctors will access the margin accurately and rapidly within 10 minutes of surgery. And it's cost effective and a compact system. So we at TerraLumen, we provide much faster decision to the doctors. So doctors and patients will spend less time on anesthesia. So doctors can attend more number of surgeries. They will not wait for the histopathology results of frozen section analysis to complete the surgery. The decision is based on entire sample and its accuracy is with millimeter precision. So this is our USP. It is much quicker and it is completely non-invasive in non-ionizing technology. So the product is terahertz plus artificial intelligence. You can see some of our fresh sample results. When sample is directly excised, we do not need to add any reagents or chemical staining to it. So this is a cancerous fresh tissue where it is a normal tissue. You can see the best out of the reflected intensity. Cancerous tissue will have higher reflected intensity.
Device to visualize the results. Our AI module improves overall sensitivity and specificity of the detection. The current device is capable of in vitro measurements, and in future we will focus on developing a terahertz probe which can carry out in vivo measurements.
As India's first terahertz company, we are not only focused on building innovation-led solutions for diagnosis of cancer margin, but also aiming to reduce the complexity and delay in surgical process, visiting a large number of cancer patients worldwide.
Thank you. So this is the video. You want me to show the product?
I'd like to welcome Dr. Sunil Shroff, President TSI TN Chapter, Senior Consultant Urologist and Transplant Surgeon. So Dr. Sunil is also associated with multiple initiatives. He is currently the president of a 1,500 member society called Indian Society of Organ Transplantation. He is also a director and chief editor of a large health site called www.medindia.net. He has established or edited over 800 articles in international, national journals, newspapers, and the web. He has written and edited 5 books, 14 book chapters, made almost 900 presentations in the form of orations, keynote lectures, invited talks, and paper presentations. His scientific publications has over 1,000 citations. Besides academics, since 1997, he had developed interest in 2 areas, organ donation and digital health. He started an NGO to promote organ donation called Mohan Foundation and a health website called www.medindia.net. In October 2020, he was invited by Sony TV to appear as a Kambir on a game show hosted by Mr. Amitabh Bachchan called Kaun Banega Crorepati. This was a recognition to the work of Mohan Foundation in the field of organ donation. It is an honor to have you with us, sir.
Yeah, good morning to all of you. I'm trying to share my screen. Is my screen visible to all of you?
Yes, sir. Just wanted to give you a heads up. So when the time is nearing, I'll just come on camera to give you a heads up about the timings. Sir, can you hear me? Yeah, please give me a minute. I'll just check with sir and I'll get back.
Sorry, I got disconnected. I don't know how.
Yes,
Am I
sir.
audible?
Yes, sir, you are. So just wanted to let you know, just giving you a heads up when the session is about to end. I'll just come on camera to let you know about the time.
Sure, do that.
Thank you.
Okay. So I think I have about 15 minutes to talk on understanding telemedicine requirements and regulations. Is that right?
Yes, yes, sir.
Thank you very much. Thank you for the introduction. And I have no disclaimers or conflict of interest. We've heard about in the last couple of hours now, we've heard about the impact of COVID on the growth of digital health. And definitely healthcare has become a priority post-COVID. It has also improved computer literacy, both among patients and physicians, and made them more empowered, I would say. The self-management is now acceptable norm to minimize the load of healthcare systems. During COVID, this is a dashboard which shows the current status, just what it was about 2 minutes back. It shows that we've had about close to 362 million cases of COVID in the world, and about 5 million deaths and so on. What COVID has done is brought healthcare to the forefront as such. And we used telecare in public health settings during COVID for surveillance, for rapid response, for teletriage, to categorize COVID into mild, moderate, severe cases, to look at oxygen beds, hospital beds, ICU beds, to do study risk stratification to predict mortality and so on. So definitely, COVID has made healthcare arrive, especially in India. Look at the budget allocation. It has gone up by 137%, this year to 2.23 lakh crores compared to 94,000 crores the previous year.
So sorry to interrupt. We are not able to see the slides moving. We are still in the first slide, no disclaimers or conflict of interest.
Oh my God, how is that? Let me see. What about this? Can you see my slides?
Yes, sir. It is an impact of COVID and growth.
Is it moving now?
Just put it on presentation mode, Sunil. It's not on presentation mode.
I thought it is 1 second. Sorry.
Just press F5. It should work. Hopefully.
No, it is in presentation mode.
Yes, sir. I think you just have to stop sharing your screen and reshare it again, where you'll see that presentation mode itself. So give share a window. In that, you'll see the presentation window. If you can just click on that, probably it would work.
Your window, yeah. Sorry about this. We're doing something. Sorry.
Or if not, if you can.
Going forward, can be for consultations, for reminders, for SI available, for various things. So depending on the type of practice, if you're a dermatology, you may want one type of app. If you're a ophthalmologist, you may want one type of an app. Because in medicine, we have close to about 64 broad specialties, and then there are subspecialties. So requirement in medicine is different depending on the specialty. And accordingly, there's a big opportunity to develop specific apps for specific specialties. So the type of consultation, the best consultation is a video consult, especially for the first consult, because it is one way of establishing a virtual relationship between patient and doctor, because seeing a doctor, nothing like it. I think with 5G coming in and with IoTs and all coming in with better bandwidth and all that, and haptics being there, it wouldn't be very, you can have a virtual doctor visiting a patient at home, and with haptics, they can even feel the patient. So a lot will happen in the next 5 to 10 years. A lot, as I said, we live in very exciting times, and I think there's much more to come in the next 4 or 5 years, especially with the arrival of 5G. Video consultation also gives better assessment, as I said, evaluation, especially of visual areas of the body, like the eye or if there's a lump on the body and so on. It is easy to visualize, or if there's an ulcer, to make a diagnosis. Prescription of medication requires a lot of work to be done. At the moment, there are limited drugs which can be prescribed to teleconsultation, but we are working on, the version 2 of the guidelines. We, as a clinician, You can do counseling of the patient, like taking medication to tell them the side effects of the medication, when to take, and so on. If they have a, you can give patient education on, let's say, if somebody has a stone, how much water to drink, if there are, what precautions to take after, a strategy of urology, to look at opinions of doctors in urology surgery who felt that where they could use teleconsultation. And we found that, for diagnosis, they were very comfortable to use teleconsultations, equal literacy, not only among the public, but also among the physicians and policymakers. There are problems with policies and regulations about privacy and confidentiality concerns, about hardware and software standards that still has to be covered better in the guidelines. There are medical challenges of accreditation of doctors. You know that in India, we have a lot of doctors who don't have the qualifications. In one study from WHO, they said that 57% of doctors practicing medicine in India were not properly qualified. Then there are problems with payment systems, insurance coverage, and of course, there's with COVID, there has been an infodemic of misinformation, and that has created a lot of hysteria. We asked our doctors in our survey what are the biggest challenges and barrier in telemedicine practice service, and many felt even malpractice and legal responsibilities. They worried about that. The time it takes for teleconsultation, also they were concerned, but sometimes it can take longer to do teleconsultation than face-to-face consultation. When we asked them about the type of platforms they use for teleconsultations, most of them were using WhatsApp, and I personally feel WhatsApp is not the best platform for teleconsultation. Very few were using third-party apps, in fact. So if a doctor wishes to do teleconsultation and they need to set up a communication process, a first consult will normally take about 15 to 20 minutes if you do it properly. The best thing would be to have pre-work with a nurse calling, taking history, identifying a patient, then checking the video and audio to define barriers. And then the doctor comes in and does an introduction and takes the consent, talks, and then they do an assessment of the patient and see whether it is possible to do teleconsultation or not. And if they feel the patient is fit for teleconsultation, they go ahead and give a treatment plan and investigation follow-up. So when we asked our doctors in our survey whether, how much of time and effort is involved in telemedicine, many felt it involved more, but most felt that it was similar to face-to-face. But I personally feel it is more, the efforts involved in teleconsultation slightly more than face-to-face consultation. To overcome barriers, we need to have adequate bandwidth. We do have last mile challenges with the bandwidth in the country. We need to have good video quality. So we should invest in a good camera. There should be good visibility. The speech you should speak slowly when you're talking to a patient. You sometimes need to make a patient repeat if they have understood your instructions or not. And as a doctor, if you're using a mobile phone for teleconsultation, you should use a different number for teleconsultation so that you don't get called at odd hours, and fix the time of teleconsultations. I always feel that desktop is a better tool to use for teleconsultation than mobile. You can be more relaxed sitting and talking to your patient. So to understand the scope of telemedicine and to do it properly, one needs to undergo training for telemedicine. So that they can understand the risks and benefits of this, to understand the privacy and confidentiality issue, and to overcome the digital literacy aspect. When we asked in our survey with our urologist doctors that whether they're aware of the telemedicine guidelines passed by the government of India, most of them were aware, but very few had undergone training in telemedicine before they undertook teleconsultation. So this is lacking, and we actually have started training for telemedicine, and we have 2 courses online available at the moment: a foundation course for doctors for telemedicine, and we also have a course on diabetes and telemedicine practice, which was developed with Dr. Mohan's group, and we have other courses lined up as well to come forward. So coming to the end of my talk, there is a changing health paradigm. We are moving away from traditional care towards telehealth care. The traditional care has been provider-centric, whereas telehealth is patient-centric care more. The cost can come down with telecare, and of course, access is better, as we suggested and seen. And evidence suggests that telehealth provides comparable health outcomes when compared to traditional methods of healthcare delivery without compromising on the patient-physician relationship. Most of the studies have shown that. And it also shows an enhancement in patient satisfaction and improved patient engagement. And when we looked at our own survey of doctors and asked them what is the biggest impact of telemedicine in urology, all this came out very well. The reduced healthcare cost enhances patients' access, increases patient satisfaction, and so on. And when we looked at the patient satisfaction, almost, we had a result of almost 78% of patients felt excellent or very good with doing teleconsultation. So patient acceptance is very high for teleconsultation. So in conclusion, the COVID pandemic has pushed us to accept the new norm. Teleconsults and digitization of data provides a great opportunity to doctors and hospitals to help patients and to give better care, so that there is better patient engagement, satisfaction, and create efficiency. And in my opinion, telehealth is here to stay, and hybrid form of practice will become the new normal as we go forward, where patients will want to see the doctors, but follow-up care many times, like Dr. Mohan said, in diabetes, a patient can be remotely monitored, and that will save a lot of time for the patient and cost of travel and waiting in front of doctor's clinic and so on. So thank you very much. I hope this has been useful. And I'm sorry there have been technology glitches.
No problem, sir. Thank you so much. Thank you for joining us today. Thank you for sharing your insights on telemedicine requirements and regulations. It was a great presentation. Thanks a lot, sir. So, moving on to the next part, we have the second expert talk, which is on teleophthalmology for Blind Free India, for which I would like to welcome Professor Dr. S. Natarajan, Chief Clinical Services and Chief Vitrio Retinal Services at Aditya Jyot Eye Hospital, and also President of Teleophthalmology Society of India and Padma Shri awardee. So he is a charter inductee in Retinal Hall of Fame. He set up the Vitrio Retina department in Taperia Institute in Bombay Hospital in 1990. He revolutionized the world of Vitrio Retina by setting up a state-of-the-art hospital, Aditya Jyot Eye Hospital, exclusively dedicated to ophthalmology. He has pioneered and improvised several techniques in Vitrio Retina and also brought global knowledge and techniques to India. He has performed more than 60,000 vitreous and retinal surgeries and has pioneered techniques and treatment of VR diseases in India. Dr. Natarajan established a not-for-profit public charitable trust, Aditya Jyot Foundation for Twinkling Little Eyes in 2005. It was Dr. APJ Abdul Kalam, former President of India, who suggested to Dr. Natarajan that he should aim to put a twinkle in the eyes of the visually impaired. The foundation runs outreach programs in rural and urban slums and tribal, and has touched the lives of more than 10 lakh people in the state and provided affordable eye care to them. He is also the recipient of several state, national, and international awards for his exemplary work in the medical field of ophthalmology. Happy to have you with us, sir.
Thank you. Thank you very much for the introduction. Nice to go after Dr. Sunil Shroff, who is the President of Telemedicine Society of India. And I happen to be Tele-Ophthalmic Society of India. I can see my colleague Dr. Sheila John and my other friends. I think in the morning Dr. Mohan Vishwanathan was there, but I think I don't see him now. And I hope Dr. Muthu Singaram is here. I'm not able to see him. So can I share my screen?
Sure, sir. Sure. Please go ahead. So just to give you a heads up, so by the end of 15 minutes, I'll just go on camera to give you a heads up on the timing. So.
Okay.
Thank you so much.
I'm sharing my screen. Good morning, Dr. Muthu Singaram and Dr. Sendil. Can you see my slides?
Not yet, sir.
Okay. What's the problem? Why we can't share?
Share a window in the...
A window, okay.
I also have some issues.
Okay, now share an application window. Answer. Share a window, your entire screen board window.
arrow which shows up is the shares one.
So if not, you can just try clicking on share your entire screen, and a pop-up box comes. There you just have to click on the screen and select share.
Your entire screen is coming. Then
yes, there will be a pop-up box. In that you can see the window that you have to share. Just click on that, and then click share.
System preferences. 1 second.
Yes, sir.
System preferences. No. Google Meet, na? Okay. Yeah. Huh? Google. Whatever now.
Also, if not, if you can share your slides with me, I'll put it on the screen for you.
But I have a video and all. 1 second, wait, madam. I think I have to.
No problem.
Remember last time I had to log out and then do. I think everybody is making it difficult. Okay, I log out and then I log in.
No, you can still do it, Dr. Natarajan.
I'm not able to work, sir. It's going to. I'm using a Mac now. It says.
Okay.
So I log out. Last time I did that for some other meeting. I'm coming back in a minute.
Sure, we can have a discussion maybe.
If anyone has any questions with some of the panels here, you can ask them while we wait. There's no problem.
Yeah, there's no point wasting time.
Yeah, so if anyone has any questions or like to ask, Sunil is there, Sindhil is somewhere there, Sheila is there.
So the thing which I wanted to say, Bobotu, is that, at the moment, we don't have in the telemedicine guidelines itself, the regulations for software, what is required and what is not required, but that is going to come soon. It is in the process. There's a committee which is formed. The telemedicine guidelines itself is a guideline which is, just for doctors on how to do safe telemedicine. As far as hardware standards are concerned, software standards are concerned, these are going to come, and I would tell all these people who are, all your startups who are, looking at this, to look at these, to take the highest kind of care for as far as security is concerned. But one of the biggest challenges which you're going to have as we go forward is the data privacy issues and confidentiality issues in telemedicine.
Yeah.
Sir, where do I get the guidelines? Is it on the?
It's all available online. If you just put telemedicine guidelines, Government of India, you will get many links which will take you, and I can also share it in the chat box.
Thank you, sir.
So yes, Professor Natarajan is back. So you're on mute.
Again, it is telling go to system preferences. Anybody knows Mac here? Dr. Muthu Singaram, sir, can you help?
Mac I have not used, but on the Google thing, there will be a thing called present now. It's an arrow on the bottom.
No, that's right, but it's not allowing me something. And entire screen is coming, but it says go to the system preferences.
So when you go to system preferences, you can search for. Let me see if I can. Yeah.
Where I go?
Just click on share. I mean, on the top corner, you have the search bar. No, search for sharing. See if you can look for that. Or even in security, I guess there is no thing on this.
Return to open.
We'll manage. Chillax. We'll manage it. We'll manage.
Were you able to get into that security and privacy? I mean,
he's dropped out again, Harisha. Just a second.
Okay.
We might be running a little late, but we'll manage. Don't worry.
Okay.
Now can you see?
We can see you.
Yeah. So now I'm again sharing the screen. Yeah. Now you can see, I think.
We can't see your screen yet. Yeah, now
Now
we can
it's coming. It's coming.
Okay. Now I can see my full screen.
Absolutely. Yes. Super.
Okay. Thank you. Thank you. Sorry for this problem
No
because
problem.
I'm
No
also
problem. It's good.
adamant using the Mac, and everywhere I'm having
It's good. Please go
Okay.
ahead.
So we talked. Thanks for Dr. Singaram and Dr. Sendil for asking me to be here and speak on tele-ophthalmology for blind-free India. I know it's a very vast aim I have, but I follow Swami Vivekananda, like arise awake, stop not until you reach the goal. And Swami Chinmayananda said, keep touching, work with the outstretching hand and keep extending your goalpost. So that's what I'm doing. So I've started with small steps. As the president of All India Ophthalmic Society in 2019, I started this screening through tele-ophthalmology to prevent diabetic blindness called Stop Blindness. We call it the Jot Se Jot Jalao. And so I'm now from the blindness I've reduced to diabetic blind free India 2025. And the main reason I'm doing this is I heard Dr. Mohan talking about diabetes and COVID and how a COVID diabetic patient need not be worried about COVID. But I want to tell that every diabetic should be concerned. I will not say not to be worried, because diabetes is the 21st century epidemic, and diabetic retinopathy is a major cause of blindness in the working middle-aged adult population and fifth cause of blindness globally, and India is ranking the capital of that. And IDF said that 415 million diabetics are there more than 18 years, and impaired glucose tolerance in 318 million. And by 2040, it will become 642 million. So we have about 77 million diabetic, with 58% do not know that they have diabetes or not. And by 2045, it can go to 134. And by 2030, it will become, according to the estimate, 8.4% of India's adult population will have diabetes. Should we be proud? No, not at all. And that's why this program, I wish the public health professionals of India, government of health ministry, and who is involved in healthcare in India should know it. Because my idea is, from the age of 30, we should have every human being checked in India. That means 1.4 billion people, wherever above 50 or above 40 should be checked. And the reason is diabetic blindness can be affect anybody, and every diabetic is affected in some form or other. And diabetic retinopathy and diabetes itself is an incurable disease. When you get it, till you go to the grave, you have this disease. The eye symptoms are too late, and that's the reason I am now talking about prevention is better than cure. So as an ophthalmologist, we recommend primary checkup at the time of diagnosis in every person. Prevention is better than cure. And primary prevention, the role of primary care physician. That means we have practitioners, we have GFAM, Ayurvedic, homeopathy, and many people involved in the diabetes care for India. So effective screening program for diabetic retinopathy, and determine who needs to be referred to an eye doctor for close follow-up and possible treatment. According to me, out of 100, only 5 may need to go to the eye doctor, 95 can go home. That means I am having a system along with the health sector, Skill Development Corporation of India, the Prime Minister's program, where we want to train any Tom, Dick and Harry. When I mean Tom, Dick and Harry, anybody who can handle a smartphone can take part in this program. So I decided every citizen deserves eye checkup, because when you have good vision, you can work well, you can improve the economy of the country and look after yourself. Me, from Aditya Jyot Eye Hospital and Aditya Jyot Foundation, we have done several initiatives for this. So we have made a low-cost screening device at Primary Eye Care Center and also in physician clinics in Mumbai. These are the one in the van, and the two is there in the small clinics in the slums of Mumbai. There are vision centers in various parts of Mumbai, in Chunambati, in Mulund, in Worli, etc. And here you can see our own health workers go door to door, check their blood sugar. We have money, we can do HbA1c, and I recommend from the age of 30, everybody should do door to door. Take the eye care program or health care program to the doorstep of people, because unfortunately they are not aware. So if you do that, they will know that at least we are doing selfless service, and we are doing from 2005. The name HTIC Jyot Foundation for Twinkling Life was given by Dr. Abdul Kalam, my great friend. So this is a screening camps which has been done all over Mumbai. We have covered about 4,200 eye camps in the last 17 years in Mumbai. And also made a study called HTIC Jyot Diabetic Retinopathy Urban Mumbai Slum Study. We use the mobile van, and we are the first in the world to use motorbike, thanks to Mr. K. Chandrasekhar. Forest camera we carried. Here you see Visucam, Zeiss camera, thanks to World Diabetic Federation, WDF, for giving the funds, and that was given in 2011, and we did this in 2015. This is a major camp we did in Sholapur. My good friend Praniti Shinde, MLA, and also former Home Minister, Mr. Shri Kumar Shinde there. We did a 3-day long mega eye camp. That's social workers and our staff in the camp there. And we also came in the Guinness World Record. Again, this is not for putting our collar up, but it is for telling that India needs this, because here we have 15 optometrists and technicians using a Remedio camera. Thanks to Remedio for supplying this, and I don't have any financial interest. I like Remedio camera because it has a mobile phone fixed to a mobile infrared device, and you can take images of retina and send it to the either offline AI or online AI or the reading centers. It became a Guinness record. I hope if everybody does this and beats each one's record, so many hundreds of people can be diagnosed, and then thereby hundreds can become thousands, thousands can become lakhs, lakhs can become crores, and thereby we can reach 77 million diabetics. So we have a process flow for nationwide screening, pre-camp awareness, assembly of diabetics, capturing the images of retina, and uploading diagnosis by eye doctor, AI, or image graders. And we want this to be integrated with the National Health Mission. And we have the central government, state government, and village. We have ASHA workers. But unfortunately, when I went and met the health ministry in Delhi, they said ASHA workers are busy with many things. They can't be taking part in this. So these are the various cameras available, which can be fixed to a mobile camera like this. So fundus on phone camera. And this is one of the comparison of fundus on phone with Zeiss, where you see the images are almost same, and you can do with a 4 lakh camera instead of a 50 lakh camera. So we have used the offline AI by Medios company, which is incorporated in the Remedio camera. Here you have an example lesion of detection by an offline AI. You can see the blue marks which can detect. And only when we can, this particular software says referable diabetic retinopathy, non-referable. So only out of 100, as I said, 5 can go. So I made a program called ABCD, where anybody can screen for diabetic retinopathy. And we have published this in the JAMA Ophthalmology in 2019, which is the highest read article in that month. Use of offline AI in prediction of diabetic retinopathy using a fundus on phone camera. And this is the results which was published. And we also have a full-time endocrinologist at HTIC Jyot. We have done the diabetic retinopathy awareness and association with multiple comorbidities, insight from the Diamond study. So I want to say that early detection and treatment after screening can reduce the prevalence of diabetic retinopathy, even in the remote parts of the country, with we having 6,47,745 villages in India, and reduction in the economic burden among poor and illiterate people, an opportunity for semi-skilled workers. It will help to improve overall health of the population. So AI, the way forward, the next 3 decades will be the most technologically disruptive era in human history. Advances in AI combined with radical breakthrough in hardware will usher in an era that sounds like science fiction today. Devices will fade away, virtual environments will emerge, and super smart AI assistants will organize our lives and run our businesses. In this new world, our relationship with technology will change forever. We will both virtually and biologically merge together. Closing the merge between this, and there's a company called PhD Media who's doing this. So this is the offline AI which I said. And you can see this in this video, where we have trained the school dropouts in our hospital, where they can take focus the retina like this and apply that in the media software, select the eye and apply it. In 30 seconds, you will get the answer whether referable diabetic retinopathy or non-referable. You can see the blue patches which recognizes the color difference and thereby detects diabetic retinopathy and says you can refer the patient to the eye doctor. And then out of 100, only 5 have to go. You can imagine the village after village follows this. Some corporates can take it up as a CSR responsibility. NGOs can take it up. Municipal hospitals can take it up. In Bombay, we are doing it free for the Bombay Municipal Corporation. I wish every municipal corporation in India can take it up along with any of the NGOs they can work with. So there are IDX system, which is 5 times the cost of what we are using, and this is the IDX system, and this is the Wisconsin FPRC study on AI. Forest, which is a Bangalore-based company, has come out with ophthalmology software. Google has come with the Google's DeepMind, working to bring AI devices to the market for detection of eye diseases. And then Google AI can predict heart problems by taking pictures of your eye. I'm glad Government of India has given Sundar Pichai Padma Bhushan. I wish some of us can do that, not for the sake of award, but I think for the sake of screening every diabetic in India. So the key benefits of AI, diabetic retinopathy, the social and economic dimension, early detection, enable specialists to focus on treatment, deep learning techniques, continuously improve outcomes, relatively low cost, highly scalable process with quick response time. And I want every management institute, Government of India, various state societies, whether ophthalmic, diabetologists, endocrinologists, telemedicine, Society of India, Rotary Clubs, Lions Club, Indian Medical Association, Association of Physicians of India to take part. And this we did in Netra Kumbh in 2019, thanks to UP State Society. Dr. Kamaljeet and Manish Tandon helped me to do diabetic retinopathy. This is what I mentioned. Anybody can be trained to screen for diabetic retinopathy. And we have made an All India Ophthalmic Society Diabetic Retinopathy Task Force. We have got Dr. Subudhi from Orissa, Rajiv Raman, Shankaranayathaya, Dr. Lalit Verma from All India Institute, and also AOF, Partha Bishwas from the Calcutta, and also Ministry of Health, Dr. Pamela Gupta and Dr. Rajsekhar. So I again want to conclude to say Swami Vivekananda, they alone live who live for others. Like this, do selfless service of screening for diabetic, prevent them from going blind, and thereby at least one part of the blindness can be prevented. Rest of the blindness, there are a lot of ophthalmologists all over the world who will do it. Thank you very much for the patient listening.
So much, sir. Thank you. Influences ophthalmology with telemedicine, also came about the various benefits of artificial intelligence. Thank you so much for sharing your valuable insights with us. So, any questions from the participants?
I think Sendil can ask question, no? Or Dr. Muthu Singaram. If you don't ask question, I don't leave the mic.
So actually, this diabetic retinopathy screening, I understand the major challenge is on the cost of the equipment. Basically, because to do a large-scale screening, we need low-cost devices. That is when we can reach all those 70 million patients, because we need a specialized camera to capture that retinal image. So, what are your comments on that, sir? How do we go about?
So I think I'm glad Dr. Muthu Singaram called. So he has caught the tiger by the tail. So now I will not leave him. So he has to develop a low-cost fundus camera in IIT Madras, and which the whole India can, whole world can use it. I think India, entire Africa, and South America. So many countries are. I think almost it will be 70 to 80 countries will benefit. What, Dr. Muthu Singaram?
We take that seriously. I mean, surely there are a lot of startups here. They can pick it up and,
Actually, I wanted to ask Dr. Natarajan one question.
Yes, sir.
You know, this video camera is using AI-based diagnosis for this, when they are doing teleophthalmology screening.
Yes.
And as per the telemedicine guidelines, this should not be done. And, and so, I find that the report instantly comes with, an AI kind of software without getting seen by a doctor, the actual images. And I think that is in violation to the telemedicine guidelines.
So I think there is something, a gap here, sir, in understanding. Here, we are not going to treat any patient through AI. We are not treating any patient using AI. And how we have published
it can be used for, the AI can be used, but not for, of course, treatment it should not be used. And even for diagnosis, it can be, used for diagnosis, but the kind of diagnosis which this Remedio guy is giving is not the diagnosis, is a diagnosis saying that you don't have retinopathy and you have retinopathy kind of diagnosis. That is, a little bit dangerous in the telemedicine space. And as far as the regulations are concerned, we looked at that.
Sir, one clarification, sir.
Yeah, I know.
According to the telemedicine thing, they say the thing can give the diagnosis, but it has to be overseen by a doctor. So Remedio is giving the diagnosis, but at Sir's clinic, it is manually overseen by an ophthalmologist. So that thing.
Yeah, I think it's very clear that even if it is normal, it has to be seen by an ophthalmologist and then.
That's all.
No, I agree. Sheila, this is what I'm trying to tell. See, I agree with Dr. Sunil Shah. Thanks for finding out the law. But what I'm trying to tell, the offline AI which we are using, even till today, as you rightly said, even though we have published 100% sensitive for referable diabetic retinopathy patients, we are still ophthalmologist is certifying every patient. It is not that. See, we have there's a school dropouts doing the fundus imaging in all the diabetic clinics, but overseas.
That is fine.
Overseas.
That is no problem. That is not a problem at all. But in the Remedio solution, not you, Dr. Natarajan.
I know that.
In the Remedio solution, which is providing to them, my hospital has a Remedio, and we have a camera which we use this, one of the iPhone cameras.
Right.
My hospital, I saw the Remedio report, and instantly the report comes. There's no doctor verification there. I'm not talking about what you're doing. I'm talking about Remedio as a company.
No, I understand, sir. You're right. Remedios, they're charging 50 rupees and generating that and writing one a disclaimer saying that it is a AI detected diagnosis. But that is what I'm saying. That is what they should not do that.
They're flouting the regulations is what I'm trying to say. Not you, Dr. Natarajan. Don't get me wrong.
I agree. Sir, Dr. Sunil, I agree with you, sir. But I think you have to point out to this august audience here, I think what is happening in the world real time is different and what is happening, what I'm presenting.
Exactly. So I'm only trying to tell the young startups here that be careful. Right. When you come out with solutions which are AI dependent, look at the regulations of the country and be compliant with that. Otherwise, tomorrow you can get into trouble. You may not get into trouble if 1 or 2 cases. When you have a large volume of cases, then you can get into trouble. But something will go wrong somewhere.
Correct. No, sir. That is why even today, I'm not able to, I want to do under the Teleophthalmic Society of India, so that we ophthalmologists, not control, but we ophthalmologists want to guide any of them who are going to use technology. And as you rightly said, it's a word of caution. And I think Dr. What's his name? Sendil, if he does, I think maybe Dr. Sheila, you and me from Teleophthalmic Society of India definitely can guide media that they cannot give a report without doctors. This one, and I think we are right. I remember seeing something even Zeiss done that with Narayan Netralia, where they say it's machine generated, not seen by ophthalmologist. But I don't know how many villagers will understand that, or anybody, as Dr. Sunil says, somebody goes blind with that, he can sue the entire thing, which is not. I think our idea is to prevent blindness. I think we have to take extra precautions. And it's a good point, sir. And I think maybe people like Dr. Sendil, myself, Dr. Sheila, who are here, part of the Ophthalmic Society of India.
One bad case, sir, will bring down the whole ecosystem. But in India, we have knee-jerk reaction, believe me.
Correct.
So please be careful. That's what
I agree, sir. And thank you for cautioning. But what I want to tell is, I use the same platform here, and I want Dr. Muthusingaram to do the homework with startup, where we use these people who are illiterate and with the Skill Development Corporation of India, train them to take only image. And after that, the diagnosis and rest of the things should be given to a valid society like Teleophthalmic or Telemedicine Society, where we supervise the entire procedure, what's happening, so that the common man is not affected. Because when Dr. Abdul Kalam, when I presented this, first question he asked me is, will you injure the patient? But I think that means he thought I'm interfering in the patient's eye. Fortunately, that this is an external instrument and you only take the photo of the retina. You can't. But again, diagnosing him normal, and in case he has a neovascularization, he can have a vitreous hemorrhage and go blind.
Thank you so much, Dr. Natarajan, for being here. And sharing.
One request to Dr. Natarajan. Sir, will you please put up your email address in the chat box? We could not note it. Thank you.
Thank you so much for it. I will connect with you offline and with Sendil and also others, and we take this forward. Sorry, Arshini.
Yes, sir. Thank you, sir. Thank you, Professor Natarajan. Thank you so much for joining us and thank you for answering questions. So moving on to the next part of the session, we have a startup demo. So we have Kepler Technologies from CIIC. Please go ahead, team. You're on mute.
Hello?
Yeah, please go ahead.
Yeah, apologies. Can you guys see my screen and hear me well?
Yeah, so you'll be given 7 minutes. So by the end of 7 to 8 minutes, just come on camera to give you a heads up.
No problem. That's fine. That's fine. Yeah, thank you, doctors, guests, for being here today, and thank you, HTIC, for setting up this conclave. I'm excited to talk to you about our product, Optimists. So I want to start with a quote that many of us know already: "An apple a day keeps the doctor away." So this is really, in many cases, the first medical advice that people are given, and certainly for me at a young age, I was told this advice. Now, if we dig deeper a bit into this advice, it's actually relating to preventative healthcare. So preventative healthcare, in a nutshell, is anticipatory measures taken to prevent diseases and illnesses from arising. So in the case of the apple, by eating an apple a day, you prevent having to see the doctor, you prevent any serious issues from arising. Now, when we first started building our technology, we were trying to understand one question: why is it that, although this is very obvious, and although we're taught this at a young age, why is it that people are not, getting health checkups as much as they should, and what is really putting people off from getting health checkups? So we did a lot of market research, and we found three main reasons. The first reason being convenience. Why should someone go out of their way, spend some time, take time out of their day to do a checkup if it's not necessary? So immediately we knew that our platform needs to be incredibly user-friendly. It needs to be very easy to use, and it needs to make the life very easy for the patient. Now, the second thing is affordability. Obviously, why should someone spend money on a test or a checkup if they don't need to, especially if you're getting it for your whole family and so on? So the way we approach this is that our technology is very streamlined, which you'll see in a second, which helps us keep our costs down and give an affordable product. The third reason people are not keen to take these tests is knowledge. So a lot of people we found are scared to do a test because they're scared of the results. They're scared not to understand what they're reading. They're worried about all the jargon. They just want to stay away from this, especially if they have no prior experience in the medical space. So using all of these, we developed our product, Optimists, which is an all-in-one platform. And what we offer is free doctor consultations. So this covers the knowledge and the concerns people have. We offer contactless health checkups, which I'll come on to in a second. And we offer wellness programs. And the important thing is that all of this is done from the comfort of your home through our technology platform. So I want to talk a bit about what makes us, about how a typical user might use our product. So maybe they're they need some advice. They talk to a doctor for free. Either the doctor recommends a test or a package, or they can go on the website. If they're already knowledgeable, they can pick something out themselves. They complete the test. They request collection, and we go and collect we collect the sample from them. This will make more sense very shortly. And the final step is that they get the results on a dashboard. Again, this is a high-level overview. I'm going to go into a bit more details on the USPs. So what does contactless self-blood test mean? It basically means that we allow the patients to take the blood test without requiring any phlebotomist or any oversight. So we've designed this kit, which is patent pending. And inside the kit, you have several components that are not pictured. You have like an instruction manual, Band-Aids, alcohol swabs, cleansing wipes, and so on. But the main components in the test section is lancets for finger pricks and microtainers. Depending on which tests you take, we'll give you the different microtainers, these test tubes, the yellow or the pink. But once you complete the sample, you prick your finger, you collect 8 to 10 drops of blood, and we're able to run whatever test that the users has selected. This is the first thing you'll see from our dashboard. I'll go into it in more detail, but once the user collects the sample themselves, they log into their dashboard. They see a button that says collect my kit, because the way we built the platform is that we know every stage of the user's journey. So we know that they're ready to collect their kit. So we show them this button. We, of course, offer for people who don't want to do the test contactless using our kit, we can send the phlebotomist, but we're always encouraging that even if we send a nurse or phlebotomist, that we use the contactless kit just to make people more aware of the service, to make people, first-time users who are maybe scared to do it themselves, we can send some help. And hopefully the future times, they can actually complete the test by themselves using the kit. So now this is the kind of exciting part. So this is the dashboard that we've designed. So this dashboard is personalized to each user. You can see it's like a modular design. It's like Lego, like blocks. And the reason for this is that every user, depending on what they need to see at that point, the dashboard moves around. So for example, here we have a user who hasn't completed has completed the test. So you can see results are available. He's getting some recipes, some tips, and some advice and stuff like that. I'll get into more detail on that. But if we take our example of the user who has purchased a blood test from the website and they completed the test, they log into their dashboard, we send them a notification, we tell them your results are ready to view. They land on this page, and this is where the knowledge comes in. We're trying to make it as easy as possible for someone to understand what the results mean. So you can quickly see a high-level overview, green, yellow, red, what needs attention. This works on mobile or on desktop, on the website, or you can download our app, and it's all very user-friendly. You want to explore a specific test, we show you a deep dive into the biomarkers. So for example, in this complete blood count test, you have several biomarkers, and we show you what's good, what's bad, what needs attention. Now, the idea is that you monitor your health. You eat an apple a day. You monitor your health, and if anything looks slightly out of the ordinary, you can act, and you can prevent this problem from becoming serious. So in this example, our user did a test in May. His cholesterol levels were high. Using the advice that we gave him, which I'll come on to shortly, he was able to, in subsequent tests, actually bring this result into a good range, nullifying the risk of any potential issues that can arise because of this. So this is this is one example of how someone would use our product. Now, how can someone improve the results?
So sorry to interrupt. Can you just wrap up in another couple of minutes?
Yeah, 2 minutes, I'll be done.
Yeah, sure. Thank you.
So we use a combination of real advice from doctors. So the same doctor you did a consultation with would give you notes on your results. But at the same time, we have some AI-powered functions. So for example, depending on your results, you get certain recipes, tips, blogs, advice, all AI-powered. So we combine these two, real life and AI, to try get people healthy. Now you can order any test online, but at the same time, we're developing a function to be able to literally go to any pharmacy, supermarket, gym, spa, wherever, and pick up the kit and take it home and complete the test. So this is more on the convenience side and affordability side. We're trying to make it as easy as possible for people to eat an apple a day to try and stay healthy. One last thing I want to talk about here is the wellness program that we have. So one thing we identified is going through corporate wellness programs. So as well as offering a general health checkup, we offer event bookings. So you can book classes, fitness classes, yoga classes, mental wellness sessions, and so on. And final point is that we've also built a separate dashboard. So the dashboard initially is for the users. We built a separate dashboard for the companies to be able to monitor their workforce. Because obviously, if you have healthy employees, motivated employees, you have less sick days, less turnover, and ultimately, the bottom line, the profitability of the company will be better. So on a final note, initially we started off saying an apple a day keeps the doctor away. What I want to tell you guys is that with optimists in play, you can keep your problems away. Thank you for your time. I do appreciate it. There's a QR code here if you want to check out our Instagram, and I've also added my number and my email at the bottom if you would like to contact me for any future demos or any questions. Thanks a lot, guys. Does anyone have any questions?
Thank you so much. So I think in the short of time, if we have any questions, we'll take it offline. Thank you so much for joining us, and thank you for explaining your product. So next startup we have is Meta Plus from VIT TBI. So Sachin, please go ahead. You have 5 minutes. Please see to that you finish your presentation. Yeah, please go ahead. Sachin, can you hear me?
Yeah, sorry, I was in mute. Sorry, yeah.
So Nader, can you just stop sharing your screen so that this team can go ahead?
Sure, thank you.
Yeah.
Thank you. Hello, I am Sachin Munji. I am head of R&D from Medev Plus, Disha's Medical Device Development Solutions Private Limited, Bangalore. So we are a company we are working on a technology called OCT, Optical Coherence Tomography. So this technology, we do the 3D imaging, where like when you see a like imaging or scanning pattern in medical field, so it happens like in a 2D manner. So if you want to get the inside view of the any of the tissues, or as the eye, the field where we are working, the ophthalmology, so we cannot the technology we work on is the optical coherence tomography, where we can see the 3D depth, from which we can tell the thickness of the layers of the retina, and we work on retina and the ONH, that is optic nerve head. So our device is majorly works on under three categories, that is software, electronics, and optics. So we work in these three fields. So so from this, what we are majorly our main motive of this device is redefining the diagnostics for home. Like the product what we are designed is the portable OCT, where we can get the device to any like any part of the world. It will be just like a suitcase model. So this is our technology, and it is completely made in India, and the optics part we are getting imported, and the complete things are built in-house. And we have got the diagnostics for glaucoma detection. So from where we will be getting the RNFL thickness, and that can be shared to the doctors, and the early diagnostics can be done through that reports. So this is a like according to the business wise, we have got 2 to 3 models where we can directly give the reports, or else we can give the image screened images to the doctors, or else the main motive of this is not only the doctors can view the data, diagnose the disease, but even a technician can get the screens, and they can share to the doctor, from which it will be easier to diagnose the disease. Firstly, we are working on glaucoma, and in later stages we are working on RNFL, and in coming days we will be working on diabetics and other neural related diseases. So we have got Shamila. So Dr. Shamila, she is a PhD holder from Calcutta University, and she will be showing our device, which is like a suitcase model, where like it is a handy, which is 6 to 7 kgs. So where the technician can take to any part of the country, to even to the village, to show the device. So Shamila, can you show the device?
Sachin, can we wind it up in another couple of minutes?
Yeah, sure. Yeah, I think there might be some technical glitch. So I'll try to display my device, where we will be showing the screen. So hope everyone can see the screen.
Yes.
Yes. So this is the GUI of our software. So we are funded from DST and VIT, and we are collaboration with Samir, IIT Bombay, and the device is developed by Medev Plus. So we have got these scans, like capturing the volume scan for RNFL, for detecting the RNFL thickness and getting the reports. And we have got the macular scan for scanning the retina region. And we have got 3 different types of performance scanning. That is for one is circle scan and long scan and the high SNR. So here the thing is the thing what we do is we scan the like we take the sample for the reference, and we can see the images here. and we can change the focus length, and we can take the width and the depth of the images, like whatever the retinal region we want to check. And this is not only for the humans, and we can go for the animal research oriented database also. So from where we can get the like we have tried in Manipal MCHP, that is Manipal College of Home Sciences. So there we have tested our device with rat, rabbit, and mice skin and eye. So from which we are get very good data, and we are going to publish the white paper very sooner in 2 to 3 days. And we have got 2 to 3 patents where we have indigenously built the optics part and electronics part. And in coming days, we are planning to showcase this and release this in the market as 2 products. That is, one is from FPGA developed, which is a very high SNR and high speed module, and another one is a suitcase model from which a normal vision technician can get the system into any part of the world. So I show a small image of retina that we have captured. This is the retina. This is the macular region, and we can
sorry to interrupt. Since we are running short of time, if you can just wind up.
Sure. Just give me a minute. Yeah. So this is the retina, and we can see the layers, 8 to 9 layers, all the ILA and GCA and the RNFL. So we can see all those layers very clearly, and we can change this as per our requirement, according to the doctor's requirement actually to tell. So thank you for giving us this opportunity to showcase our technology, and we are very proud that we are the one and the only company who are working on this technology in India, and we want to make it made in India product as soon as possible, and which will be a more user oriented product. Thank you.
Thank you, Sachin. Thank you so much.
Any queries? We are open.
So queries, due to a short of time, we can take all the queries offline. We'll check with the participants and we'll connect them with you. Thank you so much for your time. Thank you for joining us.
Thank you. Yeah, thank you.
So moving on to the next part of the session, we have the second panel discussion where we have diverse speakers speaking on tele-ICU, telehealth, and various other topics. We have diverse speakers joining us. And to moderate the panel, we have with us Ms. Padma Chandrasekhar, angel investor and management advisor. So Ms. Padma Chandrasekhar, being an angel investor actively seeking opportunities to invest in promising young startups, she has worked in senior and executive level positions for 18 years in the for-profit and 8 years in the non-profit and research sectors in India and abroad. Her private sector experience followed a standard gradient of developer, manager, executive officer, and entrepreneur in the IT sector in India, US, and the UK. She was a founding member of Sci-Fi Limited and part of the team that took it public on NASDQ in 1999. She subsequently founded, ran, and then successfully sold a web services software technology company. Between 2003 and 2011, she worked for Bill and Melinda Gates Foundation, where she had responsibilities for strategy development, program management, and impact evaluation in various areas of public health, research, and services. She continues to consult for international health tech and research organizations. Since mid-2012, Ms. Padma has pursued opportunities in angel investing. Her current angel investment interests include biotech, health, and clean energy. She is on the advisory board of a mobile technology company enabling logistics and supply chain management for essential drugs, vaccines, and devices. She has authored several highly cited peer-reviewed papers in premier high-impact journals such as The Lancet and the BMJ group of journals. Happy to have you with us, ma'am. Over to you to introduce the panel members and start with the session.
Thank you very much. That seems like an overly long introduction, which has eaten up half of our panel time, but thank you anyway. I'm delighted to welcome such a diverse group of participants to a panel on innovation in telemedicine. Dr. Amit Gupta from Med Path Labs, I think, welcome. Dr. T. Sendil, we meet again, I think, when you were running WellCare. I know you're still running WellCare. We met a couple of times. Dr. Sheila John, a great, very, very great pleasure to meet you. Dr. Vidya Ramkumar, again, likewise a pleasure. And Mr. Harsh Murur, I mean, I think you are the odd one out in this group because you're running an IoT and connected devices company. I looked up your website yesterday. So welcome all. What I'd like to do is to give each one of you a minute to maybe talk about yourself, your experience, introduce yourself. And then after that, we do that once round robin. Then second round robin, maybe each of you can take a couple of minutes and ask you, talk about what you see as the opportunities, the evolution, how telemedicine and generally technologies have changed in the last 15 years. So maybe Dr. Amit Gupta, you can start with an introduction to yourself. Take less than a minute if you don't mind. A minute or less.
Yeah. Hi, I am Dr. Amit Gupta. I am a radiologist by profession. And I did my graduation, post-graduation from BG Medical College, Ahmedabad. And post that, I also did a MBA from ISB, Hyderabad. Since then, we are into diagnostics. Me and my wife both take care of radiology and pathology. Talking about telemedicine, since last 3 years, I think that is the main time when the telemedicine has made a lot of difference in what we were doing in the normal, the conventional diagnostic space. I'll more focus on telemedicine and diagnostics. So what we are trying to do now is we kind of developed a few telemedicine things in pathology. So to try to make it brief, so what we are doing is in telepathology, we're trying to cater tier 3, tier 4 cities and few villages also where we are able to put some cameras on the microscope. From there, we are able to capture the images on the slides and take it on the cloud. And diseases like malaria, some kinds of anemia, some kinds of leukemias are instantly kind of diagnosed on the slide. Last time when there was a pandemic of dengue and a few portions of Gujarat, it was very handy and we were able to save a lot of lives in that. So yeah, that's about a brief discussion what we're trying to do.
If I may ask a clarificatory question, so when you said you're capturing slide data, basically you're taking a blood sample or a smear and then on a slide and then in a remote location, is that what you're doing? And then you're capturing it on a camera?
Yeah, we're capturing the slides on a camera and we're taking it to the cloud so that a pathologist sitting on a remote location can see what's happening on a...
Whatever. Yeah, very interesting. That's a nice innovation. Okay, so Dr. Sendil, maybe you want to talk about all the work that you've done in ophthalmology, if I remember correctly.
Yeah, thank you, madam. Nice to meet you again. And whatever Dr. Amit Gupta does for radiology, I do it for ophthalmology. I'm an ophthalmologist. And we get those retinal images of all the diabetic patients from different locations, and these images get uploaded. And we have a team of doctors who do the reporting for those images. Started this company around 6-7 years back, and from the time we have started, we have done screen almost 2 million patients. So we are actually, though there are 70 million diabetics in India, so we are reached a considerable size of them, but would like to expand more to reach out to more number of patients.
For the benefit of the audience, do you want to expand a little bit more about how you do what you do? I remember you had a very interesting model.
So basically, every diabetic patient needs to get his retinas checked at least once in a year by an ophthalmologist, because this disease called diabetic retinopathy affects 1 in 4 of the patients. So, but on the other hand, India having only 20,000 ophthalmologists, so it's very difficult for the ophthalmologists to wait for the patients to come into those centers. So what we do is we go to the places where the patients go. Like say if a patient is going to a diabetes center, or a patient is visiting a lab or a government primary health center, these centers are equipped with a camera, a specialized camera to capture the images, which we train the staff in the center itself to capture the image. And these images are uploaded into the platform. So just like teleradiology, where the doctor gets the CT or MRI reports, we get the retinal images. And then our team of doctors can log in and give back the report. So the turnaround time is around 30 minutes. And If the patient has a problem, we refer them to the local ophthalmologist. If he is normal, we just ask them to come after 1 year.
So it's a high skill KPO, but not yet using AI of images.
Yes, as of now, we are not very confident of the AI, and still, as being ophthalmologists, we still want to have doctors to look at all those images.
Of course. Dr. Sheila John, it will be great to hear a little bit about yourself and all the fine work that you do. I think you may need to unmute, or somebody should unmute you.
Yeah. I'm an ophthalmologist from Shankar Netralaya. I head the teleophthalmology department. Recently, I completed my PhD in computer-assisted screening of diabetic retinopathy from Tamil Nadu MGR University. What we have is teleophthalmology. We cater to the rural population. In 2003 itself, teleophthalmology units were started in Shankar Netralaya with the help of Indian Space Organization. The satellite connectivity was mounted on top of the bus, and they go into the rural villages and examine the patient, and then the findings are put into the EMR, and the anterior and posterior segment images are uploaded, and consultation was done with the ophthalmologist at the base hospital. By 2013, we started shifting to internet connectivity. Of course, we had problems with the last mile connectivity, but I think by 17, 18, internet connectivity has improved a lot. So we were able to do a lot of teleconsultations. We have examined more than 7 lakh patients. Another innovation which we have done with HTC is our mobile eye surgical unit. We have 2 vehicles, one is preparatory and one is the thing. Where this vehicle goes into the rural villages, there it conducts the cataract surgeries. We have one in Tamil Nadu, where we have done about 11,000 cataract surgeries, and one in Jharkhand, that is 2000. This was started in 2011, and the other one again done by the HTC. They have done it for Jharkhand. 2016 it was started, and we have completed about more than 6,000 cataract surgeries.
Amazing, Dr. John. I think when on the second round robin, definitely we want to hear more about your thoughts for the Dr. Vidya Ramkumar, yours is a field that was ripe, I think, for tele-intervention. So we want to hear what has happened. Well, first of all, about you, and then, what your experience has been so far, and what has happened, what can happen in the future.
Very good morning to everyone. Thank you, Ms. Padma, and thanks to HTIC for inviting me on this panel. I'm an audiologist and speech language pathologist, and many may be even curious about the profession in itself. So just to give an idea of what I do, I help people hear better as well as speak better. And my focus has primarily been on children with disabilities, even though we provide services to adults as well. And I've worked in the space of telemedicine for the last 13 years. I began with my PhD work in telemedicine, where I think a decade ago, most people were still validating whether telemedicine works in certain disciplines. And that was true for the discipline of audiology, particularly, to say whether I can remotely test somebody's hearing. And my focus the setting that I have worked has been a rural setting in Tamil Nadu, so predominantly Kanchipuram district, Kadalur, Thiruvannamalai, now in Perambalur and Ariyalur districts, where we empower local community workers to be able to do the screening aspects, not necessarily using telemedicine, but sometimes using mobile health as well. But really, how do we plug in diagnostics after we've done the screening? Because there's plenty of technology currently available to do screening in various modalities. But really, it would be unethical to do a screening and say, we don't have anything else for you. Now you come to this hospital and that hospital, which is 200 or 300 kilometers away to get your diagnostics done. So the focus has been to see how do we take diagnostic services closer to people using telemedicine. And currently, I'm working more on translational work, where I'm working with the government of Tamil Nadu to see how can we integrate this in the public sector, because coming from the private side, the only way this can reach and really become a part of a sustainable effort is to integrate it into the public health system. So that's the work that I'm currently doing. And the focus is using implementation science to do that, rather than be top down about saying that you need this and so you do this to the people that you're catering to, but use a more situation analysis, need-based system. So that's what I'm doing right now.
I couldn't agree with you more about scaling. I think you have to go to the public sector at some point if you really want to reach the last mile. And fully agree. And your focus on implementation science and bench to bedside translation science is fantastic. So maybe when we come back, it'll be good to hear a little bit more about the diagnostics that you do, the specifics. But in the meanwhile, maybe Mr. Harsh Murur, you are the odd one out. You come from the world that I originally came from, which is all IoT and technology. So maybe you want to tell the group what your company does and how you came to be. Well, maybe first of all, a little bit about yourself, and then how you came to be in this area and what you do.
Sure. So, hi Padma, everyone. Again, I guess rightly I'm the odd man in this whole panel. So my background is primarily into computer science. So I did my engineering first, and also I have a master's in business from HTIC Paris. So that's around the educational side of this. But I've been, passionate about actually solving problems, using technology all throughout my life. So even when I was young, I was looking at solutions to my own problems using technology. So the problems with healthcare accessibility as well as the quality of care is what I wanted to primarily solve, and that is where Tesla came to be. And even before that, I was working for Cisco, wherein I spent about 6 years working on various different solutions. And then in 2015, when I started off Tesla, we launched this platform called Care Nation, which again, I mean, since you're from the VC world, people would say that, focus. But then our idea was not really to kind of build a, let's say a unicorn sort of, but rather build a transformational enterprise, which can actually cater to the needs on ground, look at real problems that the doctors or patients are facing around care delivery, and tailor Care Nation as a platform to solve different problems or challenges that we see on the ground. So we have started off from a kiosk kind of a telemedicine model, which was the norm back in the days, where we enhanced that model such that everything that you could do in an in-person consultation, sitting across the table to the doctor, could be replicated on our platform through a virtual consent. All these transactions and interactions, like stethoscope or any video scope tests or any other things that you want to do, we were trying to replicate that. So doing this, we also focused on some other things which were really important when it came to building a healthcare platform around standards and norms that were there in the West, which were not followed here. So we built a platform that was compliant with global standards, so we could build something in India, make it work in India. But also we replicated that in EU in a couple of countries. We have done this in Latin America. We have done this in the Middle East, where our platform is serving telehealth needs as well. And also from the simple teleconsultations, we have gone into tele-ICU monitoring, carts for doing COVID care. We did a lot of work during COVID time, and that's where we got associated with HTIC as well. And we continue to do so as a journey in terms of looking at what's the impact that we can create by bringing in tech. So we are limited in a way where we kind of partner with hospitals, with government organizations for the actual care delivery, but we act as a platform or the tech side of the story which enables that care delivery process.
If I may call you Harsh. So you start with kiosks, which are to me the very low end. You walk into, it's like a typical walking into a Walmart, do your blood pressure check, that sort of thing, as I presume, in a lot of services that your kiosk offers. Your high end on the other, which means suppose a doctor who's not on duty gets an alert if the patient suddenly spikes or something like that. So do you want to elaborate a little bit more for the benefit of the tele-ICU bit? For example, I connect a Philips something to some other kind of monitor, whatever it is. You want to elaborate just to benefit the education audience.
Yeah. So in terms of what we do specifically, right? I mean, there are different solutions when it comes to tele-ICU and how it's implemented. So what we do is we do a combination of both visual aspect and then the data aspect of things. So we connect the bedside monitors or infusion pumps and other things that are there and the and we collect that data and then transfer them remotely, where the doctor can can actually take a look at the patient in real time. Also, along with that, we have like a rig that actually has a camera on top of it, along with the device gateway. Video-based monitoring as well. We have these cards that are suited for conditions. That's like, you know, a 3-step where the cards are used for the virtual rounds or late night in the ICU, or even in the COVID times, the cards were helpful where the specialists or the intensivists, like the scarcest that we have, so they could be in a, say, kind of a control room and they monitor patients, or let's say COVID and, you know, ICUs without having to get a respiration.
Right. So how are we doing? We'll take another 15-20 minutes. So it'll be good to get a second round from each of you, particular field. And what innovations are you seeing? What innovations do you anticipate? Dr. Gupta?
Yeah, am I audible?
Yes, you are.
Yeah. So we're doing a very interesting startup called Neos HealthTech. So we're doing that startup in the we're supporting that startup that is incubated in IIT Madras. So what we're trying to do is we're trying to create something around teleradiology. So it's an AI-based startup where what we're trying to do is we are trying to build a platform which will be a self-learning platform. So when I say a self-learning platform, we're trying to build a teleradiology platform where as the radiologists are reporting on that platform, the platform is learning more about how to annotate the images on the platform itself. So what happens is after we say we have around 1 lakh or 2 lakh studies on the platform will become so intelligent that it will again start telling the user that, you know, these are the abnormal areas in the imaging. We have already done a prototype for COVID in chest, in thorax CT screening, which is almost 98% accurate now when we saw the results as compared to what a radiologist can do. So that's something which we are trying to do, AI, which we are trying to do on the imaging side. Next, what we are picking up are infarcts and hemorrhage on the brain screening and MRI. So that's how we are trying to take it forward.
So if I may play that back to you, Dr. Gupta, so what you're doing is you currently have some humans annotate images, but that data is then filed away and used in a learning mechanism for an AI to sit and for then, you know, further look at the next 10 images and annotate them. And then you have, of course, a cycling process where somebody corrects it. Is that correct?
That's right. That's perfectly.
Interesting, interesting. So it would be, we'll come back to you and maybe the audience will also have questions. So Dr. Senthil, maybe you want to say a little bit about, you know, what you see as the future. You were always very unhappy about having any AI do the work for you. And I know you have a team of experts reviewing the images. Has your view changed now, or is it likely to change? Or, you know, what else do you see as the future?
No, actually, we are not against AI. We are definitely, because it's not something which we can avoid using, but we are of the view that AI should not be independently doing. That is the only view we have. And more important, the innovation in ophthalmology which has to happen is the collaboration between the doctors, between the equipment companies, the AI companies and software companies. I think that collaborative ecosystem has to develop, because only then this large population can be addressed. Basically because, see, even in the instruments in diabetic retinopathy screening, why many of us are not able to reach out to a large volume of patients is because of the cost of the equipment. So that is where the device manufacturers or people like HTIC should come forward and create that low-cost equipment. So if we suppose we see, if we get right now these fundus cameras are at least 3-4 lakh rupees minimum, can start getting it at 50,000 rupees. Then we can provide this equipment free of cost to all the labs and other players, and then we can start charging only for the reporting. So that is when the whole model will scale up. So a lot of innovation has to happen in terms of equipment development and low-cost equipment, particularly for countries like India, and then the collaborative ecosystem has to be developed.
Interesting. So that's a wake-up call for you, HTIC. And maybe we'll come back to you and the audience has some questions. So Dr. John, you gave us some really interesting examples of the kind of work that you've done with HTIC, both on the ground and as well as in research. Do you want to expand a little on what your plans are for the future? What you see evolving with teleophthalmology?
See, initially we conduct rural camps in Tiruvallur and Kanjipuram district. And initially because of the COVID, the government did not give us permission. We got the permission only in March 2021. So when we went into the villages, we had to safeguard our team members as well as the patients. So implementing masks and sanitization. And the room earlier we used to allow at least 20 patients, now restricted to 5. Only when 5 finished room. And slit lamp examination takes a longer time, 10-15 minutes. So we developed a slit lamp guard between the team member and the patient. Even if accidentally one of them drops anything, it will not go on to the other person. And refraction also, we made many changes. Where we used to use gadgets, we use the patient's hand, his own hand to close his eyes. So that the gadgets each time cleaning the solutions would be difficult. So many innovations we had to make because see, all these people they have many chronic diseases. So 6 months at least they should have a review or an examination to be done. And the rural patients during COVID time, they were not coming forward to come to our center. So we had to go into the villages. That's what many innovations we have done like this. Each time when we go and come back, we learn something new.
Right. So a lot of the innovations seem to be, tiny, but life-changing in terms of, going forward. More patient self-service, as you're saying, the patients, you don't have to clean the surface, etc., etc. Is that correct?
Yeah.
I mean, I'm not devaluing. I'm just saying these are really important, but they're tiny, but add up to a big, dramatic impact.
The number of patients we saw earlier before COVID and what we saw during COVID time were almost half. Because the precautions has to be done, more than a lot of patients cannot be allowed. So the number was less, but then we could visit more often. Instead of doing it in one stretch, we did 2 visits and we did. And for diabetic retinopathy also, HTC only I did my PhD again. We developed an algorithm which we can use, but every case which was diagnosed by the algorithm was overseen by an ophthalmologist. It's not just that thing. And there are some cases where the dilatation, because camp cases you cannot dilate. Government does not give us permission to use dilatation drops. So it is not dilated fundus imaging. So sometimes the patient, even though one feature is there, patient requires dilatation. So we used to bring the patient to the main hospital.
Right.
Yeah. We used AI, but every case was overseen by an ophthalmologist.
Right.
Because it's a blinding disease.
Interesting. So, Dr. Vidya Ramkumar, maybe you want to talk a little bit more, and I'd really like to hear about the diagnostics that you mentioned. I'm assuming it's diagnostics for hearing loss or something.
Yeah, so the focus, as I said, since it was a rural area, we empowered the local community workers, which at that time we partnered with some NGOs to train the local health workers to facilitate telepractice. So if it's a hearing test and we use something similar to EEG to assess the hearing of newborn babies. So you have to plug electrodes and place headphones and clean the skin and all of that. So we trained the health workers to be able to do that in the community. And we had set up our equipments there, and then we remotely took over these equipments and conducted the hearing tests. And the broader outcome was, of course, in terms of follow-up, how many more people were able to access a service as against having them come to the hospital to get the same test done. So that was our effectiveness outcome indicator, as well as an economic analysis in the incremental cost effectiveness of having that one extra child follow-up. What was it? What did it mean to the provider, and what did it mean to the person, to the society at large? So that was the outcome. And of course, we found that telepractice was beneficial to the provider in terms of low initial capital investments are high, but recurring costs reduce, and to the patient as well, because they avoid the cost of travel and wage loss, which is true for more for persons in the rural community who are dependent on daily wages. So that was the learning 10 years ago. But going forward, I mean, since this audience is more technology driven and they're looking for partnering over these solutions, I just wanted to share some thoughts around the current areas of work that I do, which is more on implementation science to plug in telepractice. I think what is currently something that requires deep meditation on is, healthcare somewhere has become an industry, and we don't know. We have to look at that one. Then we have the doctor who wants to do more for the patient, but also be able to use technology to be able to increase base and access. And we have the patients who need access to services, and then we have technologists who want to increase their base as well, but somewhere want to bypass the need for human beings in this whole, especially to provide the service, and so that the base increases. That's where a lot of AI is coming, and I'm also following the chat box questions around these. So you see that each of these stakeholders, even though everybody somewhere wants to increase the base for access, the viewpoints are very different why they are doing it. And that's when I think what Dr. Sendhil said also is about looking at this collaboratively to see that finally we are addressing what we are meant to address, which is the need of the patient. Are we aware of that? Now, many of the solutions that are coming up over and over, and there's just plenty, every single day there's something new coming up. And it really looks like it's again catering only to the large city population that already seems to have access to many of these, right? And ultimately, are we really increasing our base? I know there are some who are doing it. It's not that they are not, but by and large, we are only having more and more solutions that are able to provide more and more to who already have it. So somewhere a lot of meditation has to go into this, and there are solutions to this, but we just need to become mindful of these so that it's integrative, collaborative, and we have that final endpoint very clearly in our head. What are we doing? Are we trying to compete with each other? One is trying to bypass the doctor. One is trying to make somebody use some technology, try to find how somebody will use it rather than say, do they really need it? And can I drop it? If it's not needed, can I drop it? Nobody ever wants to drop an idea. They really want to finally make it work. So I think somewhere a lot of mindfulness needs to come to healthcare overall. And I think that's where I stand today, because much of my work is in understanding these aspects and being graceful sometimes to say that what I thought for you is not what you want from me. So let me give you what you want, right? We're all happy only to receive what we want, right? Not what other people decide for us. I think that same sensitivity in healthcare would be very, very useful going a long way. The second point I wanted to raise was some of the people here were looking at solutions based on what they're seeing in these COVID times. And telepractice has definitely been a boom in these times. But I just want to caution, just around with the work, since I come from an academic background, I have the opportunity to interact with researchers and implementers across the world. And what the trend is, whatever has picked up during COVID has also gone down whenever the wave has settled down. So I would really caution anybody to take up anything because they see this as a potential during COVID. It's not likely to sustain beyond. People are having a huge internet fatigue, virtual space fatigue, and they all want to get back to seeing their doctors. So that's the other thing that I wanted to share based on what I'm now learning from interacting with various people around the world. So yeah, so those were my thoughts.
Very interesting, Dr. Vidya Rangula. Harsh, maybe you want to have the last word before we throw it open to the audience to ask questions.
Sure. Yeah. Again, I guess if it's the last word, then probably I would start with the word empathy. Right? I guess that is what is required when you are working in this space. Be it on the tech side, be it being a doctor, or be it being the trained person on ground who is trying to talk to the patient. And Vidya rightly said, you need to give a solution where it's required and not really kind of push a solution on someone because you have an idea. And that I see happening a lot. And again, while we look at the urban population and say, they have access to everything, I guess there is also this whole challenges when it comes to accessibility of care for patients within the urban area as well. There might be a person who is staying right next to a super specialty hospital in Bangalore, but then he might not have the insurance coverage or the money to access the care provided by that institution. And government hospitals in, let's say, a metro versus government hospitals within, let's say, a tier 2 town, I don't know. I mean, what is the difference that you find? So now the point is also the focus on insurance or creative methods on how you can do this fully, and also the exact point that comes about is, how you can deliver preemptive care, or try to kind of look at early screening. And that's where I feel AI is very apt and most important. Even when we started our journey with bringing in AI into the systems, we had ambitions that were grounded, not really kind of say I'm Google or IBM that can do better than doctors, or I will decide treatment plan for cancer patients, which is being too ambitious. I'm not saying it's bad, but at the same time, what's probably needed on ground is to bridge that doctor-patient divide. Okay, look at technologies that can augment the doctor capacity, can help streamline, do intelligent triaging. And I feel those technologies are the ones that are most apt for countries which are developing like India, and even in places where we call them developed countries, but then still they have shortage of care or problems like accessibility of care. So I guess a major thing is to look at solutions to actual problems on ground, have empathy, look at yourself in the patient's shoes, in the doctor's shoes, try and see how we can make their lives better. And that I would say matters, to kind of serve healthcare or serve in healthcare or to the patients.
Thank you. Great points, everyone. So before we throw this open to the audience, any last words that anybody volunteers to say, or you're all done? Okay, done. I think you've probably been on this conference for quite a long time. So with your permission, Muthu, as usual, we'll throw this open to questions from the audience. I think, Harshini, you have a system for moderating, right? People write their questions in the chat box.
Yes, ma'am. I'll be checking.
Or I saw that somebody just raised their hand.
Pranav Kumar, do you have a question?
Yes, ma'am.
Yeah, please go ahead.
So, ma'am, thanks a lot for such an enlightening conversation.
Wait, before you start, please, can I say something? Let's keep them as questions, not as statements. Then we will be able to cover more. Okay?
Yeah, sure, sir. Sure.
Go ahead.
Yeah. So, sir, my question is... so, ma'am, my question is... what do you think that things which are keeping telemedicine behind, and second is how can we overcome it? So I'm asking from an entrepreneur's perspective. I'm working on my healthcare startup idea.
Is it behind? First of all, I mean, that's a question I have for the panel. And then if you think it's behind, why?
No, actually, telemedicine is not behind, it is coexisting. So basically, just like conferences, so we cannot say this online meetings are behind. Online meetings are coexisting with the physical meeting. But what I understand is the physical still has a lot of value. So maybe physical is 60-40 in a conference scenario, or in healthcare, maybe telemedicine is 90-10. So they're coexisting, and so they're not trying to replace each other, definitely. Both of them will supplement each other.
Very good answer, Dr. Sendil. So
I just wanted to come in here for the same, if I may.
Sorry, go ahead.
Yeah, so I think if you're looking at telemedicine as an application in the wrong place, then it will be behind. If you're looking at it in the right place, it will be forward. So if you're addressing the correct need through telemedicine, and like Dr. Sendil said, they are not too different. You're not trying to replace one with the other. So if you find the right application, it'll work there. It need not work everywhere, and that's not the goal of using the tool. Telemedicine is basically just a tool, right? And the tool need not work in every place. So it will have its place, and if you find that right place, there it works. So, and if it's not suitable for it, there it doesn't work. And so we need to figure that out.
Right. Excellent.
Specialist care, if you take, doctors are not there in the rural villages. Most of the doctors are in the cities. So when you want to take specialist care to the rural villages, especially, you have to use telemedicine. But again, when you go to the rural villages, the telemedicine is not an earning thing. Most of the teleconsultations are done free. the rural side where the need is more because specialist care is not there. We have to get in telemedicine to provide good care in the rural villages. But again, I wouldn't say that the earnings from it will be good. Most of our hospitals which are there, they are doing free teleconsultations.
Right. That was the part really change in the future, but maybe we should move on to other questions unless anybody else from the panel wishes to add something. Any more questions?
I would just want to end, by saying that if you're an entrepreneur and then you're looking at telemedicine, probably right now it would be about innovating on the business model rather than innovating on the tech side. On the tech side, there is a lot of different solutions already there, which have been able to kind of do a lot of things like what we have done. There are like others who have done the same thing, and you can innovate and continue to innovate on the tech side as well. But then when it comes to India and rural India, it's about trying to innovate a business model that can scale, that can be viable. So that is what we need to work on.
Thank you.
Go ahead. I think Sachin, you had a question. Can't hear you.
You're on mute, Sachin.
Yeah. So actually, I like the point that Mr. Harsha brought up, innovating the things. So it will be very helpful that people like us, what we are doing, are completely research based, and since it is completely made in India, and we are working on quite a number of things for telemedicine, and both on for clinics, small clinics, vision technicians, and portable things for telemedicine. So can we are there any options for having some subsidies for patents and or else something like that? If anyone has some idea over that, can we have some options?
I think I'll take that since my panel may not be fair to answer that.
Yes,
As you are an incubator at VIT, they should be able to tell you which are the patents available. TST and DBT and VT do that. So if they're not able to help you, connect with me and I will help you.
Sure, yeah.
Okay? Because it's not fair to ask the panel on grants and patents. They are not working on those areas. Right? The incubator should be doing that.
Right.
Thank you.
I think Sunil Shroff had an interesting question, which was how do you include the costs of AI services in practice? I'm assuming, how do you cost a practice which uses AI? That's your question, Sunil?
Yeah, sorry.
No, don't worry. I saw that question earlier. Does anybody want to volunteer for that? See, I'm assuming if nobody's answering that question, that usually you will use AI with, not in place of. And the time I'm seeing AI being used, for early screening and then for confirmatory diagnosis, you always go to a doctor. So you probably cost it as part of the overall consultation fee, I'm assuming. Dr. Amit Gupta, maybe you have something to say on that.
So, what I would like to do is, in our case, how would you include the cost of AI services in practice? So what will happen is, the very first point why we even thought that we need AI, like what Vidya was telling, whether it is needed or not. Are you just because you have a tool you want to implement it? So what we saw that the third biggest cause of deaths across the world was misdiagnosis, which was a very big revelation for us. So we thought that as a diagnostic practitioners, we are the backbone of the practice. So if we can, actually implement AI to get better diagnosis, I think there's nothing to worry about the cost at all. Because ultimately in India, if you're doing any healthcare thing, you have to, if you want to succeed, you have to make it more affordable. Unless you make it more affordable, unless the cost goes lower, there is no adaptation in India. You would not be able to make that thing work in India. So what we're trying to do is, in our case, especially Dr. Sunil, what we're trying to do is we're trying to enable the radiologists do more cases in lesser time. That is where the radiologist becomes more viable for a radiology center. and at the same time that AI cost gets absorbed because of that margins made. So healthcare becomes better for all the stakeholders in the ecosystem.
Right. And radio are short. I understand.
Can I answer this question? AI, yeah, AI, which is very useful in the rural cases, because the rural villages, especially for a case like diabetic retinopathy, we were to take the fundus photographs. At that stage, sometimes the last mile connectivity with the ophthalmologist is difficult. So if a AI is there, it will be able to tell whether it's normal or patient has diabetic retinopathy. Let's diagnose. So sometimes the last mile connectivity is very, very difficult. Doesn't help. So those times, but right now, because AI is not allowed to give the diagnosis as per telemedicine client, it has to be overseen by an ophthalmologist. So wherever cases it says the presence of the disease, it's brought to the base hospital. Again, the ophthalmologist examines and does everything. So in villages, it's very useful. And most of our ophthalmic equipments, they come with the software AI. You buy the equipment, you pay like 1 year or 2 years like that cost, because AI again they develop the next year. So for the year you pay the cost for that software. It is integrated with the equipment and it comes with the equipment. So we use it. And of course, for the rural village, the cost of the equipment, AI is all either donation or the hospital absorbs it. Here again, the payment question is not there. That is very much needed because specialists are not there to do the work.
Great perspectives. So, I mean, I don't know if there are any other questions from the audience, Muthu. We are nearly at your target time of 13:40. In fact, we may be...
We are always on target. It was a 10 minutes issue on the tech. Okay, you know me. I'm never late. Okay, there was, and I couldn't cut a Padma Shri who's come all the way to give a talk to me a shot. I had to give him his time to and I messaged Harshini, don't cut him off, give him his 15 minutes. Because she would follow my instruction and cut everybody off. So, and I must say, I mean, before I give it back to Harshini, I must say thank you to Sendil and Sunil, who really helped me put this together along with the HTIC team. So Sunil, can you come on camera? I know it's 11 o'clock, it's 1 o'clock in Seattle, but since you're here, you may say come. So I want to especially thank both of you for helping me put this together and writing the program. Thank you, gentlemen. And Padma, thank you for doing this. I shouldn't be hogging the... So,
welcome to hog the hire.
I shouldn't be hogging the time. Let's not be. So,
thank you for the opportunity, sir, for giving us to participate in this program.
Thank you.
Absolutely. Harshini, sorry, back to you.
Thank you. All the best.
Sure, sir. Thank you so much. So, thank you so much, ma'am. It was a great panel. We had diverse speakers, as mentioned earlier. We had a radiologist, we had people speaking on telemedicine and ophthalmology, in hearing tests, and also we had a startup explain about how telemedicine can be used in intensive care unit. It was a great panel discussion, and thank you so much for moderating a wonderful panel, ma'am.
Thank you.
Thank you so much.
Okay, good luck.
I actually asked the intern to speak quickly.
Yes, ma'am. Yes, sir. So before moving to the vote of thanks, I just want to inform if anybody needs any help in terms of startup, we would be happy to help you all. So you all can connect us so that we can help you all. So moving on to the vote of thanks, I would now like to welcome Ms. Jeevita to give away the vote of thanks.
So good afternoon. It's my pleasure to deliver the vote of thanks on behalf of IITM HTIC. Firstly, I would like to thank our CEO, Mr. Muthu Singaram, for his unstinted support and guidance for this event. I would like to thank our faculty in charge, Dr. Mohanashankar Shivaprakasam, for his presence and his support. I would also like to say a special thank you to Dr. Manish Diwan for joining today's program and for being a constant support to us. I would like to extend our sincere thanks to our keynote speaker, Dr. Mohan, and all the moderators for their excellent job on impressively moderating today's panel, and the speakers in the panel discussions and the expert talks for their valuable contribution and insights. I'm further thankful to all the startups who have taken their time to share their knowledge and demonstrate their innovations with the participants. We were pleased to have your presence. I'd like to personally thank my colleagues Harshini, Sumitra, and Gayatri, who coordinated with all the participants and helped in the overall management of the conclave. Finally, I would like to thank everyone present here again for your valued time and support for making this day a memorable one. Thank you.
Thank you.
Thanks a lot, Shivita. So thank you all for joining us today. Thank you for your time. We had a wonderful session. We had different domain experts. We had Padma Shri awardees joining us today. Thank you all for giving your time. So hope to meet you all soon. Bye.
Bye. Enga leave meeting.